I declare open this hearing of the Senate Community Affairs References Committee's inquiry into the Aged Care Bill 2024. I begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders, past and present, and I extend that respect to Aboriginal and Torres Strait Islander people here today. The committee will be conducting today's hearing via video conference and in person. My name is Senator Marielle Smith. I'm chair of the committee, and I have with me today Senators Pratt, Kovacic, Ruston and Urquhart via video conference, and Senator Allman-Payne in person in Canberra. These are public proceedings being video streamed via the Parliament's website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. Commonwealth officers appearing today are reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised. A copy of the order is available from the Secretariat. I remind people in the hearing room to ensure that their mobile phones are switched to silent. I would now like to welcome representatives from the Office of the Inspector General of Aged Care. For the Hansard record, I ask you each to please state your full names and the capacity in which you're appearing today.
Thank you, Senator. Ian Garth Yates, Acting Inspector General of Aged Care.
Thank you, Senator. Paula Pearsall, Agency Executive Director, Office of the Inspector General of Aged Care.
Thank you, Senator. John Sutcliffe-Power, Report Section, Office of the Inspector General of Aged Care.
Thank you very much. I now invite you to make a short opening statement if you wish to do so, and at the conclusion of your remarks, I'll go to committee members for questions. Did you have an opening statement, Mr Yates?
Yes, I do, Senator. Can I say firstly that we welcome the opportunity to appear before this committee and its inquiry into the bill. We also warmly welcome the introduction of the bill as outlined in our submission, which we've provided on Monday. This is a really important point in the reform process. We emphasise the importance of new legislation in our submission, in our 2024 progress report on the Royal Commission recommendations, in our 2023 report prepared by the Interim Office. This bill is vital to building and maintaining momentum towards positive changes in aged care that the Royal Commission envisaged, and ultimately ensuring that older Australians and their families have a better aged care system. Its passage this year for a July 2025 commencement is, in our view, of critical importance to the reform process. I just would also like to emphasise that in appearing before the committee to discuss the bill, the Office and I are obviously informed by our Act, the Inspector General of Aged Care Act. We are an independent oversight agency. We monitor, investigate and report on the Commonwealth's administration, regulation and funding of aged care to promote greater accountability and transparency and facilitate positive change. Our remit does not include designing and implementing aged care policy. However, it does specifically include reviewing and reporting on the implementation or otherwise of the recommendations of the Royal Commission into aged care quality and safety. And therefore, the focus of our submission and our testimony today will be in regard to the Royal Commission recommendations. They are our overarching principles. We are, if you like, the custodian of the Royal Commission recommendations, and we will comment on the consistency of the bill with those recommendations. I might just have a little caveat, which, like everyone, we do not obviously have the benefit yet, with one exception, of reviewing any exposure drafts of the rules, and quite a few of the provisions of the bill. How they will operate will depend on those rules. I would just like quickly, Senator, to touch on a couple of key points from our submission, but I won't go through all of them. First is what we've called the fundamental architecture of the aged care system. Currently, the aged care system is rationed. The Royal Commission recognised that a rationed system will continue to result in people not receiving the care they need in a timely way, or sometimes not at all. They called for a universal entitlement based on assessed need, coupled with certainty of funding. They drew a direct comparison with the age pension system, which gives people automatic access to a pension if they meet government-determined criteria. The bill continues a ration system. We have presented the case for a move to the Royal Commission's approach, which is consistent with budget integrity. The bill and the government's announcements about support at home do go a very substantial way toward a better system, but it will still leave people on waiting times and waiting lists. Secondly, embedding older people's rights is a fundamental part of the Royal Commission's recommendations, and this bill makes substantial strides in that direction, but we have some questions and uncertainty about the degree to which it enables individuals to exercise those rights and the clarity of the process. There are many other provisions of the bill that we welcome. We would, however, draw attention to a concern which we've repeated in successive reports with regard to the development of to training requirements in aged care, specifically that people should be required to have certain basic training, as the Royal Commission called for, in dementia, in palliative care and in cultural safety. It may well be that the rules will provide for that, we don't know, but the bill does not require it. It creates a framework for it. Dementia care, end of life and palliative care and cultural safety are fundamental core business for aged care providers, and we strongly support mandatory training being a condition of registration. I won't go through the rest of the items in our submission as you have them, and we're happy to comment on them. Can I just say in closing, whether or not there are amendments to this bill to address the issues we have raised, it is a good bill in terms of the Royal Commission recommendations, and we have made suggestions as to how it might be strengthened in regard to those recommendations, but it is our strong view that this bill should be passed. It represents significant advances in line with the Royal Commission. It could go further, but it is a very significant positive shift in the aged care system. Thanks, Senator.
Thank you very much, Mr Yates. Just before I move to questions from senators, I'm advised that there's a photographer from AAP in the room, and I just want to confirm with witnesses that you're comfortable with photographs being taken.
Yes, quite comfortable.
I'm going to pass the call to Senator Kovacic. In the first instance, Senator, I'll give you a nudge just before 15 minutes to rotate the call. Thank you, Senator Kovacic. Oh, you might be on mute, Senator.
I am indeed. Thank you all for your time this morning. I wanted to get a sense of whether the Office of the Inspector General was consulted during the process of drafting, and if so, what that process and that consultation looked like.
Thanks, Senator. No, the Office of the Inspector General wasn't consulted on the drafting of the bill. During the preparation of our 2024 progress report, which we referred to in our submission and I provided in advance, we sought out from the department a detailed briefing on the exposure draft and the responses that were coming in on the exposure draft, which the department provided fully, responding to our questions and queries about the exposure draft. But in terms since then, we have not had any particular briefing on it. We are, as I said, an oversight agency, so there's not a requirement that we should be consulted.
Thank you. And I appreciate that. I was just curious as to whether, in terms of your role in oversight, whether there was any communication in relation to those elements. And I do note your comments around it being a bill that you would support and that it makes significant advances in line with the recommendations of the Royal Commission. Are there any elements that you would suggest that we need to focus on where it doesn't uphold or not effectively uphold the recommendations of the Royal Commission?
Thank you, Senator. I guess, firstly, I have, in my opening statement, drawn attention to the fact that the bill maintains a ration system. And if I can illustrate that in terms of support at home, and there are many very positive things about the proposed support at home program. If you take the bill and what the government has said as policy, it is the government's intention that it would resource home care packages so that there is no wait time longer than 3 months. And if that blew out, which it certainly has dramatically in recent times, that they would then put more packages into the system. However, that is a matter of government policy, budget, process, etc. The difference between that and the system that the Royal Commission recommended is that if you pass the government's assessment criteria for getting a package, you would get it. Just as I said, you would get an age pension. And so that is concerned. The Royal Commission also recommended that we should have an integrated, seamless, comprehensive aged care program that had different components within it. At the moment, what we have is still a residential care program and, in principle, a home care program, although supported home will not bring in Commonwealth Home Support Program activities any earlier than 2027, and there is not a clear, that's not a deadline, it won't be before then. So how that would happen still to be right. In terms of the other issues that I raised, we are concerned that, there is an excellent statement of rights in this bill, but how the individual, through complaining to the Complaints Commissioner about not having those rights honoured, how the individual realises those rights is not actually fully clear to us. It seems that there's a path that goes through the Complaints Commissioner, then and certain actions can be taken, but then if there's persistent non-compliance, then it passes to the Quality and Safety Commissioner. And certainly in our consultations with consumer representatives, it's not clear to them exactly how, and communicating how you would exercise those rights is really fundamental. Many people in aged care do not complain. They are fearful of complaining, and they need a really clear understanding of how to do that. So how you exercise those rights does not seem to us to be as clear as the Royal Commission indicated. And indeed, in many cases, for example, the Aged Care Quality and Safety Commissioner is, for example, under this bill, are required to promote certain things like high quality of care and to encourage its provision rather than, for example, to require it as an absolute. Now, obviously, one supports and should have a continuous improvement regime, but the notion of high quality care being an expectation is a little unclear. I've also mentioned the issue about training requirements, and we feel quite strongly, and the Royal Commission did, that there are certain things that you absolutely ought to have trained staff for, and indeed the Statement of Rights says you have a right to have people with training, the qualifications, the skills and experience, and those include dementia, palliative care and cultural safety. I draw a parallel. I would not have an electrician come in to rewire my house if I was not absolutely sure that that electrician was fully qualified to do that work. And yet, I could have a family member in a facility with dementia, cultural safety issues and dying, and be attended to by staff who are not qualified in any of those. Now, we can't achieve that overnight, but it is a significant issue.
And I think it is, and that was going to be my next question to you, or to get some clarity on in relation to those three elements, which you actually called, I think the basic training and the fundamentals of aged care. Do you have concerns around the fact that not much has been done in this space as yet, and how long it will actually take us to effectively to catch up to ensure that we actually do consider those three elements effectively, and what a process to begin that might look like? So
let me be clear, thanks, Senator. Let me be clear, there are training programs and so on in place. They are promoted. I myself, in a previous a role was involved in the promotion of end-of-life and palliative care training. The take-up of those, if you look at the whole population of aged care providers, really still leaves it something to be desired, and that's why it really, we think, requires that it be compulsory, and then you have a program, so that either you are trained or you have to go into training, and that's, unless you make it a requirement, I regret to say there are providers who will not take advantage of the opportunities that are there. Can I say that in many other respects, this bill picks up Royal Commission recommendations, so I don't just want to be seen to be holding up the critical thing. For example, for example only, the governance arrangements that the Royal Commission recommended are very substantially implemented, as indeed they have been already by some legislation, but cemented into this bill. And they are quite, in terms of your question about long term, they are quite critical, because if you don't have your board knowing what's happening in all those areas, then the incentive to do those things down the chain is much less. And if the board isn't accountable for those things, then the same issue applies. And so that's a really strong, and there are many, many other examples of where this legislation is way, way in excess of what we've had requirements to date.
Do you have any concerns with the amount of delegated legislation references in the bill?
Senator, this is always a contentious issue in different views. I don't believe that the amount of stuff that's in the rules is in any way disproportionate to the norm. We are merely caveating, and I would say it in positive and negative terms. There are things that we might have concerns about that are not clear to us because the rules are still to come. And, you know, we've had the first set rolled out. It may be that some of our concerns are covered in the rules. For example, the rules may require that there be compulsory training for dementia, palliative care and cultural safety. It's just that the main architecture of the bill doesn't, and yet this is fundamental to what this industry, what this sector is about.
Thank you. In your role as obviously having the oversight of the recommendations to the sector, do you think that the bill adequately balances the requirements for, you know, obviously providers have to provide care transparently by ensuring nurses are spending more time, you know, actually caring for older Australians? And then we have that, you know, tension of the regulatory compliance and the paperwork that they need to do. Do you have any concerns in relation to that and the balance between, you know, the regulatory and necessary compliance paperwork versus actually delivering care and the impact that has on providers?
Thanks, Senator. Firstly, I'm aware that this is a very live issue for providers. We get quite a lot of that feedback. Implementing the Royal Commission recommendations necessarily has imposed additional regulatory requirements on providers. That was an outcome of the disturbing degree of lack of quality that the Royal Commission found. And if I might say, a regulatory response is to be expected from a Royal Commission, which of course predominantly, apart from Commissioner Briggs, was made up of lawyers. So it is kind of inevitable. On the other hand, can I say it is important to regularly review the full spectrum of regulatory requirements to look at whether they continue to be required, whether they're fit for purpose, whether the way in which they're being applied is efficient and effective. And indeed, it may well be that the Office, the Inspector General and the Office in the future could take this up as an issue in the administration, Commonwealth's administration of aged care. It's a related question which you mentioned there, which is the amount of data needed to meet those regulations, and there are two issues there. One is, as you'd be aware, the Commonwealth has allocated very substantial sums to improve its business to government interface so that providers can download straight from their systems into the government system. That is the intent, and that's to be commended. It also requires, of course, that providers, and they vary enormously in this, themselves invest in the kind of technology that means you only have to enter the data once, and that data you need on the floor for ensuring that you're monitoring and care plans handing over, etc. All of that kind of data collected real time rather than after the event. So it is a complex question. It should be kept under review. But as I said, I do think the additional regulatory requirements at the moment are an inevitable outcome of the situation the Royal Commission found in its responses.
Thank you.
Thank you, Senator. I have a few questions now, then I'll rotate to the Deputy Chair and then we'll be coming back to the opposition after that rotation. Mr Yates, can you just talk us through your current work plan and how it relates to the reforms proposed in this bill?
Thank you, Senator. So our current work plan, in which we have just published, includes the fact that we have underway, was part of our last year's work plan, we have underway a review of the My Aged Care system as an entry point to, I just clarify that, there are many people who use the term My Aged Care to describe the whole aged care system. We're talking about the point of making contact with and then getting through to a successful assessment. We are reviewing that. In terms of our Act, a review is a very detailed, highly procedural process with lots of natural justice provisions, etc. We estimate, for example, that the minimum time you could do a review under the provisions of our Act is about 6 months. We have that review underway, and in the process of that we are learning a lot of things about requiring production of information, etc. So why did we choose that? We chose that out of a long list of potential review topics because we had a lot of stakeholder feedback that there were issues there. We had feedback indeed from members of Parliament that there were issues about My Aged Care, and it hadn't actually been as detailedly reviewed by the Royal Commission as other areas of the system. So we've initiated that, and our work plan anticipates that we will conclude that this year, subject to what we find, which may need to extended inquiries. Secondly, we have, if you like, a placeholder that says we would anticipate announcing another review during the year and commencing it. That depends on the progress of the review and indeed on resources available. The Office of the Inspector General has quite limited resources for reviews and reports. And the other component of our work plan is that we are required under the Act, due to amendments that were passed in the Senate and accepted by government, that we produce, as we produce this year, the 2024 progress report on implementation of the Royal Commission recommendations, which substantially informs our submission on the bill. We are required to do that again for 2025, and we will commence the processes surrounding that next month in November. So we have also a placeholder that indicates and acknowledges that we have a lot of stakeholder input, that we should produce reports on other substantive matters in the sector, some of which might be touched on in this discussion, some of which are touched on in comments I've already made. And again, it's really a question of how much resources we have to undertake a solid, robust report in addition to the requirements of the Royal Commission. We also, we haven't flagged it, but I will mention it because you asked in relation to this, we also have a requirement in the Act that by the 1st of March 2026, we will have undertaken a full-scale review of the implementation of the Royal Commission recommendations. And clearly to present that to the Minister, for the Minister then to table by the 1st of March in 2026 will require us to substantively complete that by the end of 2025. So we will basically, the office will basically roll from the 2025 progress report into the review. The two will obviously inform, the processes of the two will obviously inform each other. That, I think, is the other parts of our work plan involve us, for example, in engaging as much as we can with stakeholders. And again, there are resource limits in that, but we seek to reach out to and engage with aged care consumers, with their family carers and families, with providers, and we've done a lot of interaction with providers. Obviously, with the department, with the Quality and Safety Commission, with IHACPA, and indeed other departments who are part of delivering of aged care, for example, Services Australia. All of that requires time and exercise, but we are constantly trying to monitor. If this bill had been in place as the government had previously intended by the 1st of July this year, which it wasn't, then clearly by middle of next year we would be starting to look at how effective those provisions were. That will become more of a challenge in terms of that 2026 review. That will become more of a challenge because the bill will only start to be implemented in 1 July. Although, that said, components of this bill have been passed in other acts that then feed into the current act. So we are monitoring those, and indeed we have commented on some of those in our progress report.
Mr Yates, I'll just pick up on this with respect to the start date. In your submission to the inquiry, you note it's imperative to ensure commencement of the new Act by no later than 1 July 2025. Just hoping you could expand on that, and if there's anything you've been hearing from stakeholders regarding the commencement of the new Act and its timing.
Thank you, Senator. The reform of the aged care system is a very substantial exercise. This is a complex system with lots of interactions, and one of the observations that we make in the 2024 progress report, which we are actively discussing with the Commonwealth agencies, main Commonwealth agencies at the moment, is to look not just at individual measures that have been introduced, but on the ground, how do they all work or not work together, and do they have unintended consequences? So I mention that to say that it's really important to get as much of the reform process as possible going all at once, because in some cases, for example, there's been a lot of work gone into developing and then explaining and getting ready for the new standards, but the new standards won't come in till 1 July. So some providers feel that leaves them a bit, there's a hiatus there. In having a reform process of this magnitude, because it's the breadth of the aged care system, it's not just reforming part of it, and it's the depth of the changes, it is important to maintain momentum in that process. And it was our judgment that, I mean, the Royal Commission's recommendation was 2023. It's quite arguable that was unrealistic. Government then set 2024. To push it out beyond 2025, I think would then have the sector wondering, is it actually going to happen? And you know, there are things that do need lead time as well. So,
thank you. And can I ask about the importance of having a rights-based Aged Care Act?
Thank you, Senator. This is one of the three what we're referring to as the pillars of the Royal Commission's recommendations. There certainly are rights of consumers in the current system. There's a charter. There are clearly rights that they have in the standards, but these have not, if you like, been front and centre to the system. And what the bill tries to make clear is that these are rights that fundamentally should drive the future development of the aged care system. And having that clear, in itself unequivocal statement, we don't have issues with the statement, it's the process of people using it. Having that clear statement of expectations is a very significant, historic, I think, development, and the bill does that well.
Thank you. In your 2024 update, you noted the importance of independence for the Complaints Commissioner. Can you explain how independence and the role of this Complaints Commissioner will support a strong complaints and regulatory system in aged care? Why does it matter?
Thank you, Senator. I think, firstly, can I say that the provisions in the bill as it has been introduced, which provide for the Complaints Commissioner to be a statutory officer appointed by the Minister, in our view, substantively meet the recommendations of the Royal Commission. It is important that the Complaints Commissioner be seen to be, but also be seen to be, perception is so important in this area, be seen to be independent of any other part of the system, right? Independent, I mean, Complaints Commissioners over history, I've been around a long time, have existed, well, commissioners didn't, but the complaints process existed in the department. That was not good. The conflicts of interest, obvious, but it was there where it existed. Then it sat as a separate entity, which meant that there was not a informing of the regulatory process of the Quality and Safety Commission by the complaints process. What the bill proposes is, in our view, a good landing place for ensuring that the Complaints Commissioner is seen to be independent of indeed the Commission, indeed the Department, etc., everybody, and of providers, but is able to use the Commission is able to use complaints to inform its other regulatory roles. It's important for consumers to believe that the person they're complaining to at the end of a complaints process is independent of any other interests in the system. That's important to consumer confidence. And can I say, many people experience difficulties in the aged care system but do not complain about it because of concerns because they are vulnerable, and whether justified or not, they have concerns. So it's really important that they see a clear path for how they can complain, and that they're protected. Not only that, families are reluctant to complain because of a fear of repercussion, and repercussion is not necessarily active, it can be passive repercussion. But the vulnerability of a person needing and requiring aged care means that there is often a great reluctance to complain. So the complaint system has to encourage and support that as far as possible.
Thank you, Mr Yates. Just one more from me before I rotate the call. Again, your 2024 progress report noted the importance of culturally appropriate aged care. Can you tell us why it's important that the Statement of Rights include that an individual's need for funded aged care is provided in a manner which is culturally safe and culturally appropriate?
Thank you, Senator. This is really important in terms of, and there are many examples, but in terms clearly of First Nations communities, there are many issues to do with interactions with government bodies, with formal systems and so on that require the system to be adaptive to cultural and other circumstances, including, of course, in terms of First Nations, but also including in terms of many culturally and linguistically diverse communities, understanding of trauma and its impact, particularly in relation to institutional care, but equally, I think, in relation to the whole process of someone coming into your private space of a home to provide services. And that, of course, is now the more dominant component of aged care. It's important because when someone from an Anglo background, for example, reads a piece of legislation such as we have here and all the supporting information, we would interpret it in one way. Someone from another culture, another historic background, may actually not have in their history any conception of what is being talked about because they don't have those kind of institutions and services. So from the very beginning of creating awareness about the aged care system through to how is it explained each step in the process to an assessment. You know, culturally appropriate assessment includes the capacity to deal with the fact that the person may arrive with a fear, and I've had examples just this week of this, a fear that if I let someone assess me, they're going to lock me up in a nursing home. So you have to be able to deal with those things, and there are obviously language issues, but it's not just a language issue. You can translate something and it still doesn't get past the cultural experience barrier of understanding. So it is really fundamental, and I think we have as a system, there are many individual providers who do this, but as a system we still have a significant way to go, but the Statement of Rights sets out that expectation.
Thank you, Mr Yates. I'm going to pass to the Deputy Chair and then I'll be coming back to the opposition. Senator Orman-Payne in the room.
Thanks, Chair. Thanks very much for appearing before the inquiry today, Mr Yates, and thank you for your submission. I'm interested in exploring a little bit more around comments that you made earlier in relation to the lack of clarity in relation to complaints pathways and where that goes. And I guess I'm wondering if you could frame your remarks in terms of what the Royal Commission recommended and then where you see the gaps at the moment on the face of the legislation as it is before us.
Thank you, Senator. Let me say firstly that the bill, in comparison with the exposure draft of the bill, in our view is stronger in this respect. The process of making a complaint, particularly about rights, which was the primary focus we had in our, is that they go through the Complaints Commissioner. But it is not clear to us, to kind of cut to the chase, it's not clear to us that if you get a persistent provider who complies with the requirement to report but actually disagrees with the finding of the Complaints Commissioner, what action that leads to. And it would seem to us clear that what you might call punitive action then is in the province clearly of the Aged Care Quality and Safety Commissioner. And exactly how that will work is something the committee might like to explore in later session. We are raising it because it is a concern to us and because we know it is a concern to stakeholders. It just doesn't seem simple, and it needs to be able to be simple and explained simply. So that's the concern. I mean, it is very clear that there is an intent to push providers into following the Statement of Rights, but as it is, to push providers into providing high quality care, which is also defined in great detail. But as I said earlier, there are lots of words about encourage and promote and so on that leave us a bit unsure as to how exactly you prove whether you're getting quality of care. There's going to be a lot of testing of this process. So it's not a, let me be really clear, it's not a reason not to pass this bill as it is. It is something that we would flag that in monitoring the implementation of the Royal Commission recommendations we would have a very close eye on, and would want to engage with the commissioners in that process. But I don't want to be overly critical, but I'm just saying I think the Commission was saying really strongly people need to be able to individually access and hold up and pursue those rights. And I'm not sure that we've got there yet. But, you know, the government department may have a different view on that.
On your reading, is it more the case that, like, when I look at it, it seems to me that the complaints processes at the moment would lead to potentially trying to encourage a systemic response. You know, provider A hasn't done this for person B, therefore we're going to ask them to lift their standard, which is more of a systemic response, whereas it's not clear how does an individual get redress for harm or consequence that they experience as a consequence of that, or am I reading that wrong? Is there a pathway to that?
My understanding is there is a pathway certainly for the Complaints Commissioner in terms of encouraging, what is it, John? Restorative approaches, for example, trying to get provider and the consumer to sit together and work it through and to get apologies for things that went wrong and so on. That's encouraged. Our concern is at the end, if you've got if you've got someone who isn't doing it, what happens? And indeed, whether or not, and this is where then the two commissioners come into play, I think, whether or not, to use your words, there's actually a systemic problem with this provider. And how, but as I understand it, the Complaints Commissioner can ask the provider to explain how they're going to implement it. In the end, I mean, obviously in the end, to be clear, there is a provision that the Quality and Safety Commissioner can use, which is to say, sorry, you're not meeting the conditions of registration. I do not see that you have a commitment to this statement of rights. And one would hope that if those kind of providers are found, that will be used. But we will have to see how future practice is different to past practice.
Yeah.
Is that fair?
Yeah. All right, thank you.
Checking with my colleague John Power, who knows this bill and explanatory memorandum inside out. So.
Yeah. Do you have anything to add, Mr. Power?
No, I think that that would be my assessment as well. There are quite a few mechanisms in the bill that in relation to the statement of rights. For example, there's a condition of registration, which is in section 144, where they must demonstrate that an understanding of the statement of rights. There's a clause 474, I believe, where the Complaints Commissioner can issue a notice. So I think there's a level of deterrence there and towards conduct which will improve the resolution of complaints. So I would support that statement.
I guess, Mr. Yates, just you talked about past performance versus future. Is there a history of the Aged Care Quality and Complaints Commission using those powers on a regular basis, or was that one of the findings of the Royal Commission that whilst those powers were there, they weren't actually being exercised as often as they should be?
Thank you, Senator. The answer to that is necessarily complex. Historically, most of the information that came to the Royal Commission related to the predecessor of the current Quality and Safety Commission, and indeed to the previous, to the ones that were extant at the time, standards. They were commissioned at a time when the Quality and Safety Commission was being stood up and the new standards were being introduced. So, yes, there certainly was that experience in the past. There has been significant change, and one of the recommendations of the Royal Commission was that the Commissioner be given significant additional powers and tools, and that has happened. And so I think that has happened both in the bill, and I might say that it has also happened in the government commissioning, as the Royal Commission recommended, the capability review of the Commission, and then moving swiftly, I might say, to implement. And I say that because I've been involved on the steering committee of that as an observer, not a player in it, but I have seen the commitment to implementing the capability review. Now there are some budgetary processes to go through, but in policy terms, very strong commitment to having a much stronger regulator. At the same time as the regulator is saying to providers, do you really need us to tell you everything to do, or are you going to get on there and have continuous improvement in your system, in which case you'll be coming to us if you've discovered problems, and we work to see how we fix them. Now that's a good way to go, but let me be clear, there are still bad providers, and the industry needs a regulatory system that helps get rid of them, although the industry itself, I think, could do more to promote higher standards and name and shame the poor providers.
And going forward, am I correct in assuming that there is one of the roles then that the Office of the Inspector General will play is to monitor whether or not those changes as they roll out are actually having the effect that's intended?
Indeed, and there are various ways that you can do reviews, and this, I benefited from long discussions with the Australian National Audit Office and the Auditor General. You can do reviews at the end of a long process and see how did that all go. You can do reviews during the process, or you can actually do what he at the time called commencement reviews. And resources permitting, looking at how the new complaints process is working is something that from our point of view is a potential commencement review because of its signal importance and because our Act actually requires us to oversight complaints processes across the system. Now, I'm not saying that it will be in a future work plan, but it is certainly a strong candidate.
Okay, all right. And obviously then there's a strong case for adequate resourcing of the Office of the Inspector General to make sure that these things are being monitored properly.
It would be my view as a person who's been the interim Inspector General for 9 months and the acting Inspector General for a year and a week, that while the government is to be commended for actually standing up the Inspector General with its own Act ahead of this main Act, which has enabled us to be on foot, and already we see reflected in government policy action on things in our reports, that this office is not resourced to do all the things in its Act that people should rightfully expect it to do.
Thank you. Thanks, Chair.
Thanks, Senator Allman-Payne. Senator Ruston, you have the call.
Thanks very much, Chair, and good morning, Mr Yates. I'm just keen to just get a bit of an understanding from you around the timeframes that are in place in order to get Australians who are in aged care or potentially entering aged care over the coming months and providers about what the transition timeframes look like in your mind, particularly in respect to the issues you've raised in your submission around the significant amount of subordinated legislation that hasn't been seen yet. I'm just interested in your understanding, both in your current and your previous role, about whether there is adequate time for the sector and the older Australians who rely on the sector to be prepared to absorb this change between now and the 1st of July 2025.
Thanks, Senator. I guess, as we've said in the submission and in our reports and in my opening statement, that is why we've placed so much emphasis on getting this bill passed this year so that it can commence as proposed on the 1st of July next year. I guess there will always be differences of view about how much lead time you need about some aspects of the provisions of the bill, but in many respects, in terms of stakeholder feedback that we have, there is a great desire to just get it done. Now, where there are things that require providers, for example, to have new software and so on, obviously there are lead time issues there, and I don't know that we have the capacity to provide a detailed critique of that. But many of the things, there are quite a few of the provisions in this bill that have been passed, subject of legislation already passed by the previous government, which you were part, and by this government. So there's quite a few of those things that are well in place. The government is, as I understand it, seeking to provide the rules, the subordinate legislation, over the next couple of months, all of it. So, or the exposure drafts thereof, which will give clear indications. And also, I think that quite a lot of what's in the bill has been discussed at length. And there have been changes, but it's been discussed at length for quite some time now. I guess it also depends from provider to provider. I know providers who proactively have set up internal working groups to monitor and be prepared for and initiate actions in relation to what it would appear the new system's going to be like. So, but you know, that should be monitored if there are particular, to state something that I guess should be obvious, if there are particular things that are just not going to make a particular deadline, then let's push the deadline out. You know, it's not about a precise date, but it is about maintaining the momentum of reform.
Yeah, look, sorry, please.
And I was just going to say, from many of the consumer, both actual consumers and consumer representatives who we consult with, there is a very strong sense of, we've been waiting a long time, let's get it done.
Yeah, look, and I don't disagree with you that we have been waiting a long time, and there's a great expectation out there in the community about these new reforms. But I suppose I'd be interested to understand if you've got any areas of specific concern as it relates to the delegated legislation, because, you know, the devil's always in the detail, and you know, as you pointed out earlier in your evidence, you know, you don't know whether some of the things like, you know, the dementia training or, you know, culturally appropriate provisions, et cetera, you don't know whether those questions are going to be answered because you haven't seen the subordinated legislation. I mean, I suppose the question is, you know, if we pass this piece of legislation, how much confidence can we have in that the outcomes sought by the Royal Commission are going to be delivered if we haven't seen this subordinated legislation? So are there any areas of particular concern in the subordinated legislation that you would like to have line of sight over to prior to the legislation being passed?
Thank you, Senator. I guess firstly to say, as I think I said in my opening remarks, the bill does very substantially, both in its new provisions and in its picking up things that have been passed over the last couple of years, very substantially implement Royal Commission recommendations. And our comments about some of them are about, I mean, our comments about the fundamental architecture are a yes or no. You either have a demand-led system or you don't. But in many of the others, it is about a judgment call, and we have raised questions where we think that what the Royal Commission intended may not be fully achieved. In terms of the rules, I think we've raised the question about the training requirements. You can make some assumptions with regard to eligibility of individuals to enter the system based on existing policy, but we don't know. For example, there are clearly some examples stated in the explanatory memorandum of organisations to whom some of the governance requirements won't apply, but we don't know till we see the rules whether there are others, because they're only cited as examples. And given the critical nature of governance and our understanding of that as a systemic issue for the sector, I'd be very, very interested to see the rules that apply to the governance requirements.
176. Yeah, direct
I mean, we are interested too in the rules around 176, which is the delivery of direct care. as described by the rules, which may or may not, because we really have not had time to absorb the services list that was released on Monday, because we were getting ready, writing your submission and getting ready for this.
Yeah, indeed, and probably, it's a balance between moving as quickly as possible to meet the expectations, but at the same time, this is a very significant change, and it would be disappointing for us to put something in place that actually had unintended consequences because we hadn't, as the oversight responsibility of government, the oversight responsibility of you as the Inspector General, or anybody else that's involved in here, that we've missed an opportunity because we didn't have the information. But back to your previous point at the end of your answer in relation to the delivery of the reforms as was largely expected from the Royal Commission. I noted on page 3 of your submission, you said that the office considers the approach taken in the bill to safeguard individuals' rights to be largely aspirational. So I'm interested in how you think that aspiration should be translated, and whether that aspiration could be better. Is it likely that there is going to be any greater clarity to be delivered by the rules as they and subordinated legislation as it's currently referred to in the Act? Is there any opportunity for that aspiration to turn into some sort of concrete reality, or do you still remain concerned about the aspirational nature of the rights-based, demand-driven versus a ration system of care access? That was quite a concerning remark on your behalf, or could you maybe unpack that a little bit for me?
Thank you, Senator. I did try. I'll try to address this a bit. It seems to us that in many of the terminologies of the bill, for example, that the Quality and Safety Commissioner is to encourage and to promote and so on, quality care, rather than that being put in its definition being required. It's complex because any human services system is necessarily going to be able to be improved in a continuous improvement way. So you don't want to rule out the notion of continuous improvement. But it's not clear to us that it will be clear to the consumer, to the ordinary person, what they can expect in terms of high quality care, and that rather than being encouraged to continually move towards it, that actually providers ought to have the expectation that they're providing the highest possible quality care. So that's what we're holding up. It's as I said, it is a judgment call. As we see our role, is to ask the questions about whether or not it's got there, which might inform the committee's questions of other people that come before it.
Indeed it will. Can I just, in moving on to sort of like the entry into the aged care system, and once again, this provision of a system that would make it easier for older Australians to navigate their journey through aged care. And so one of the recommendations of the Royal Commission was around that the combination of home care and community programs and residential care needed to look like it was a much more streamlined process. I note in your commentary that you are concerned to some degree about that. Just, I suppose, happy just a bit of a broader explanation, because it's mentioned in your report. I'd like a little bit more detail on that, and also about how you think the 800,000 or so people that are currently receiving community-based programs, how do they get included in post-2027? And it seems like that there's an entire piece of this particular recommendation of the Royal Commission is completely missing from the bill that's before us. I'm interested to understand how you think that recommendation is either can be delivered, given the absence of any mention of it in the bill.
Thank you, Senator. I would say yes. We have named in our 2024 progress report and in this submission the two key architectural issues. One is the on-demand system, and the second was the Royal Commission said let's have a single aged care program that you enter, which can be then it can be carried out in different settings, and that. Although I don't think the Royal Commission fully articulated this, it was saying we need more diverse settings than the significantly similar institutionalised approach that we've had to residential care. So they said a single program that you have access to, and then it would be, and you know, at a very simple level, Senator, you can be on a home care package and receiving a set of services, for example, that are about you keeping connected in community, being given community transport to go to certain social events, etc., groups and so on. And if for some physical reason you actually need to go into residential care, you're then in a different program and you don't get those things. That's at a very basic level that I've seen examples of. And the notion the Royal Commission had was if you need and benefit from those set of services, you ought to get those set of services wherever you are. So at the moment, we will still have a residential program and a home care program. In my opening remarks, I think I said that as what we understand of supported home, it's a significant improvement on the current home care package program. However, we don't yet have even an integrated seamless home care program, and government has made a decision that will not happen before 2027, but there's not at the minute a commitment that it will happen. I would observe, I was talking to a former colleague just last evening, reflecting on the fact that the first attempt to create a single home care program goes back to 2015, and I think there's been a couple of other attempts since then. Forgive me if it sounds a bit facetious, but I think it's potentially a systemic issue as to why we can't get a single home care program up and running. Because, as I understand it, it is not clear, to answer you, how Commonwealth Home Support Program activities will become integrated with what we know as supported home at this point. At the moment, supported home is a significant improvement of home care packages, but CHSP sits over there. And we have actually named in our report a concern that, given that CHSP, Commonwealth Home Support Program, is for many people the entry service level, that it is not transparent. We don't know about waiting lists in it. There are attempts to work out, but there's not the same kind of waiting list that there is for home care packages. We don't know about service needs anywhere near as much in that area as we do. That is a concern, and it is not clear to us that there is a definitive plan as to how you integrate it.
Senator, at this point, I'm going to rotate to Senator Pratt, and then I'll return to you after Senator Pratt's questions. Senator Pratt.
Thank you. Mr Yates, can I ask, please, from your work, what you've seen happen in terms of services on the ground and improvements in the system because of the increases in pay rates for aged care workers?
Thank you, Senator. I would say we don't have any greater sources of information than the department and other parts of the system do. But yes, let's be very clear that implementation of the Royal Commission's recommendations with regard to better pay, and you know that's not something that you can just wave a wand and make happen. They had to go through a long process in the industrial relations system, and the government's full funding of that, and the implementation of the Royal Commission's Care Minutes recommendations. We are certainly hearing that that is making a significant difference on the ground in aged care in terms of recruitment and in terms of time available for face-to-face interaction with residents as those care minutes apply. That they obviously don't apply to home care, and there are other issues which I think the additional funding and the additional levels in the home care program are designed to address the need for additional time in home care, which has slipped significantly over the years. But in terms of residential care, yes, certainly many providers have said that these are having a very positive impact for them. Obviously, that varies. You know, there are providers out there who don't have much trouble attracting and retaining staff because they invest heavily in their staff, and there are regrettably others who have a lot more trouble because they don't invest the same. But yes, let's be clear, that shift in wages, that historic one-off shift, which now needs to be maintained, and indeed, I think governments are and should be aware and need to do more to look at actually wages, conditions and so on across the whole care sector, because we're still getting robbing Peter to pay Paul actions of people recruiting nurses, state health systems explicitly targeting the aged care system, etc. We need an overall strategy.
Well, and speaking of an overall strategy, and you've pointed to the distinction between aged care residences and services at home. In your work as Inspector General, how do people want to age, and what does that mean for the future supports that needed to be provided in the system, especially at home?
Thank you, Senator. Our experience would be exactly the same as the experience that the Royal Commission had, and which undertook explicit research about, quite detailed research, which is that the vast majority of Australians would like, when they need care and support, would like to receive that care and support at home. And frankly, we need to remember that, roughly speaking, from 2016, when we had about 60,000 home care packages out there, to today, we're encroaching on 300,000. In the time frame, that is a revolution. That is a revolution. But it is clear from the unfortunate waiting periods at the moment that even more people want to be supported at home, and that is very clearly their preference. And it means that, well, that's what the design of the supported home program is trying to respond to. So, for example, the design of the supported home program brings in higher level packages. Some people I know have criticised it's not high enough, but I say it's a very substantial jump from where we are now. Let's see how that goes.
Where are we now in terms of the maximum levels of support that you can get at home compared to where we'll go?
Roughly speaking, Senator, it's about we're going to jump from about 50,000 as the top level, or in the 50s anyway, up to high 70s. And then there are potential for supplements and so on as well. I think that's a significant jump. And in terms of government's announcements, it has announced that there will be a significant increase in the number of packages available. So,
and I presume that's still cheaper than care in an aged care residence.
Sorry, I didn't quite catch that, Senator.
Is that still cheaper than care in an aged care residence, depending, of course, on how high your need levels are? I presume there's some overlap.
Yes.
Yeah.
There is some, but generally speaking, yes, it is cheaper for government to provide the care and support in home. Apart from the care costs, there is the fact that there are quite a large percentage of supported residents in residential care,
Yes.
and the government's picking up their accommodation costs. So, yes. But can I say that we also need a robust and responsive residential care system that actually people can go to if they need without being frightened of it.
Most certainly.
And these reforms are moving us in that direction.
So in terms of reducing the waiting times for home care, how important is that in terms of keeping up with demand in the system? And I guess the only way to reduce wait times will be through more places and the funding of more places.
Yes, I mean, one should say that it is also important as a society and as governments, not just the federal government, we look at addressing issues in our community like ageism, like age discrimination, like the need for health promotion and illness prevention programs.
Yes, very much so.
All of those things are really important in terms of reducing the demand for aged care or putting the demand off by some years. And they are really
difficult to. Yeah, thank you. I had noted it's quite difficult to access exercise programs for seniors in all communities, even in metropolitan areas. But I will just leave that anecdote there and thank the chair and thank you for answering my questions.
Thank you. I'm returning the call to Senator Ruston, or to Senator the opposition, whoever is seeking it. The opposition. Senator Ruston, are you there?
I'm here, thank you. Apologies, I was on mute as usual once again. Sorry, Chair. I know we have a couple of minutes left, and I'm just sort of reflecting back on a couple of the questions in terms of timeline and the importance of delivering at a certain point, but also ensuring that what we're delivering is fit for purpose and doesn't have any unintended consequences. Are there any specific things that could be here in the legislation that would assist in, or in the subordinate legislation to assist in delivering on a timeline? Like, is there something that, could be built out in a better way or in a more constructive manner?
Senator, I will give some reflection to that question. I would say that hasn't been a primary focus for us in our review. Nothing has jumped out of us as to say this is not doable. There are issues that you raised and others have raised with regard to unintended consequences and different things working or not working together. We have drawn attention to those in our progress report. They are to do with things like we think there are unintended consequences in terms of the diminished use of allied health services, and that really needs examination. There are not simple care minute type answers to that, but there are significant issues there that need to be addressed. But you also should say there always will be these kind of issues in implementing multifaceted reform. We made comments, for example, about the greater use of enrolled nurses. Now, in fairness, let's be clear, that was the Royal Commission that recommended that the care minutes only applied to registered nurses and carers and didn't bring in the enrolled nurses. But there's clearly an issue there, and government has made a response to that. Whether that response is itself sufficient, we will see over time.
Thank you. Senator Rudd, please, had a question as well. Thank you, Senator Kovacic.
Thanks. Just following on from that, in terms of the change to the 10% of work, in terms of care minutes being able to be relied on for enrolled nurses, was there ever any consultation done with the Office of the Inspector General as to the determination in relation to the 10% being the appropriate number?
No, Senator, not in relation to that specific response. We had exchange with the department about the general issue before that decision was made, and as you'd be aware, we drew attention to it in various reports, so no, there wasn't, and that, as I said, that needs to be monitored. My understanding is that on the ground there are some issues around how you turn 10% into viable shift periods, and certainly that needs to be monitored.
So I think that's obviously a question we can ask the department. Just wondering, in relation to enrolled nurses, there was also an issue in relation to allied health being included in the care programs for older Australians. Has this been an issue that has been brought to your attention at any time?
Thanks, Senator. Yes, it has, and we drew attention to it in the progress report, and we expressed concern that allied health provision appears to be going down, and there are mixed responses amongst providers. Let's be clear. There are some who have actually invested more, but there are others who've invested less, and we recommended that government look at that as a matter of some urgency.
Okay, thank you. In going back to the previous questioning in relation to what I would have thought are the two very significant concerns that you've raised in your report, one being the rationing as opposed to the on-demand system, the other one is the single aged care program. Do you believe that the framework of the bill offers the opportunity to be able to resolve your concerns that you've expressed in your report, or do we need to be doing would significant change be required or amendment to this bill in order for us to address those two quite significant concerns you've raised?
On the issue of a single comprehensive and seamless program, this is a judgment call. That is not something that was agreed in principle by the previous government or by this government in terms of moving forward with this bill. And to my judgment would be that passing this bill has much more value and benefit for the older Australians that it's in the end meaning than holding it back to rethink whether we should have a single program. But the office will continue to draw attention to that issue in our reports on Royal Commission recommendations. With regard to the question of an on-demand program, to establish that as, what did the Royal Commission say, a universal right, would require an amendment to this bill. It is possible for government to decide that there will be, for example, no more than a 1 month or 2 months. It has said 3 months, but it could decide that there will not be any significant waiting time and that it will automatically provide packages when that wait time blows out. Our reflection in regards to the Royal Commission is that is a decision of government. It's always revocable in budget processes and so on, compared to what the Royal Commission recommended, that it should have the same characteristics as the age pension system, which of course you'd be very familiar with, which says if you turn 67 and you meet the income and asset test criteria, you will get your pension.
I suppose the difficulty in this, and I'm interested in your views on this, is it's all well and good to have the funding and making the allocation, but timeframes can sometimes be impacted on things that are outside the scope of government. So, what kind of provisions would you anticipate need to be put in place in terms of workforce and resourcing to enable this to happen? Because it strikes me as that the lack of urgency in terms of workforce is probably going to be the most significant barrier to the ability to move to a demand-driven system, even if there was the capacity for that to occur.
Thank you, Senator. That's a really important question. I would draw a distinction between saying that if government were to say we will have a demand-driven aged care system, then it would become very clear if people were being assessed and became immediately eligible and couldn't get it, not because they couldn't get a package, but they had the package, but they couldn't get services. So clearly workforce and other system capacity is of concern and needs to be addressed. And I don't know that we have time, and it's not entirely our job to do other than point to the fact that it is an issue. And we need to invest, as I said earlier, not only in an aged care workforce system, but in a care workforce system. But yes, one of the reasons that we said in our report that you could only achieve a demand-driven system in the medium term is not because if government made the in-principle decision to do it, you then have to address workforce and other provider capacity to do it. And can I say that the demand-driven issue is likely to start to apply also, or shortages start to apply in the residential sector as well as in home care?
Yeah, sure.
Senator, we ask you to rotate if this could be the last question, and then we'll move to the next one.
Yeah, no, of course. I was just keen to understand, whether in your current role or in your previous role as the head of COTA, whether you think that older Australians understand what is the communication mechanism? Are you confident and comfortable that the communication mechanisms that are proposed are in place, are proposed to be in place, will provide older Australians with the kind of information they need to be able to navigate what is already a very complicated process, and reforms in and of themselves are always inherently complicated, whether you are satisfied that older Australians will be able to have the information they need in a timely way in order for them to understand the changes that are proposed to come into place on the 1st of July.
Thanks, Senator. In our progress report, and I haven't pre-marked that up, but in our progress report and indeed in our interim report, we did draw attention to the fact that although the Commonwealth has cited quite a number of initiatives that it's undertaken in the information space, that we did not see an overall strategy. And yes, I do think that's really important, because as much as we can say to people, oh, you should plan ahead for your aged care needs, the behavioural reality of people is they're not going to do it in detail until they need it, or indeed well into needing it. So we do need a system that is more responsive, and in terms of one of the earlier questions, is really culturally appropriate, because the aged care system is alien to the vast bulk of older Australians, but particularly to people who come from different backgrounds and circumstances, and indeed many First Nations. So no, we don't have a systematic approach. In terms of getting in close to the system, as I've said, we have underway a review of the My Aged Care, and that may well cover some of those questions in terms of what's actually happening, because we do know that people don't understand the My Aged Care system.
Thank you, Mr.
Thank
Yates.
you, Chair.
Thank you, Senators, for your questions too. We appreciate you providing evidence with us today. We're reporting to the Senate on the 31st of October. I don't believe you took specific questions on notice, but in case I missed that, we are asking responses be returned to us by close of business on Thursday, the 10th of October, but you're free to depart. We'll just pause for 30 seconds, Senators, just while we have a reshuffle at the table, and we welcome the next witnesses. It looks like we have witnesses at the table. And I would now like to welcome representatives from the Aged Care Quality and Safety Commission, including the Complaints Commissioner. And I believe we do have the Independent Health and Aged Care Pricing Authority with us as well. Thank you for appearing before our committee today. For the Hansard record, could I ask you each to please state your full names and the capacity in which you are appearing today?
Thank you, Chair. My name is Michael Pavan. I'm the Chief Executive Officer of the Independent Health and Aged Care Pricing Authority.
Chair. Janet Anderson, Aged Care Quality and Safety Commissioner.
Thank you, Chair. Louise McLeod, Complaints Commissioner at the Aged Care Quality and Safety Commission.
Thank you all for appearing before our committee today. I'd like to invite you to make a short opening statement if you wish to do so, and at the conclusion of those statements, we'll be inviting members of the committee to ask questions. Do you have opening statements?
You go.
Thank you, Chair. I have no statement.
Okay. Chair, nor do I.
Wonderful. Okay. I'm going to start the call in the room with Senator Allman-Payne, the Deputy Chair. Senator Allman-Payne.
Thanks very much, Chair. I'm keen to understand how the Act changes the process of someone coming forward with a complaint. We heard from the Inspector General that having confidence in the complaint system is very much at the front of mind for consumers, and that in fact leads to their confidence in the system more broadly. We also heard from the Inspector General that it's not clear at the moment, given we don't have all of the rules, precisely how that complaints process works. So I guess I'm keen to understand from you what your understanding is around this particular issue. So maybe if I could start with, as I understand it, the Statement of Rights and the Quality Care Standards are central to this framework, or the new framework, but they're not required to be part of any agreement, aged care agreement, which means that they're not contractually enforceable, and they don't include consumer rights. And if I understand it correctly, then the main recourse in the Act is for an aged care recipient to lodge a complaint with the Aged Care Complaints Commissioner, who can determine the remedy. I'm wondering if you could walk me through, let's say I'm a family member of someone in aged care and there's a very serious issue. I have a serious complaint. It's potentially criminal, maybe not, but it's of a very serious nature. Could you walk me through the process of where I start, and then I might have some questions along the way as to how that proceeds? Because I think this is really important for us as a committee to understand in looking at how this legislation is actually going to work in practice.
Thanks, Senator. Look, anyone can make a complaint to the Commission, and so if, as you said, a family member was concerned about something that had happened to their loved one in care, whether it's at home or in a residential aged care service, they could contact the Commission as they do now. We provide services by phone, or they could contact us online through our website. Or they can speak with an advocate, such as someone from OPAN. In the first instance, in the context of the bill, we would be looking, as we always do, at what the risks are to that older person and triaging on that basis. If there is an immediate severe risk to the older person, we would be making sure we get the necessary information from the complainant and speaking with the provider straight away to be able to ensure that that immediate risk is being dealt with. Now, in the context of the bill, we'd be looking at the Statement of Rights and also having regard not only to the Statement of Rights but the Statement of Principles that apply, and also the strengthened quality standards to ensure that the provider is actually meeting their obligations and that they're having regard to the rights of the older person. And part of that initial triage conversation that we would be having with the older person or the complainant, because they might not be the same one and the same, is to educate them on what their rights are and provide them with information so that they can make an informed decision about what outcomes they would be seeking. We would then be using the powers that we have currently in the complaints process, but in addition the powers we would have under the bill to obtain information from the provider either under notice or voluntarily, and making an assessment as to whether or not, along with other information that we have available to us, because providers, we gather a lot of information from all sorts of areas, such as serious incidents, our scanning of the environment, what we've seen through previous quality and site audits. We'd be doing all of that as we do now to get a complete picture as best we can of what's going on at the provider.
So can I just stop you there? So my mum's in an aged care home. My mum's dead, by the way, so this is not real. My mum's in an aged care facility. She's got pressure sores, which it becomes very apparent to me are not being dealt with. A, she's getting more of them. B, they're getting worse. I'm concerned that when I talk to the people at the provider that she's not being cared for appropriately. We're having difficulty getting access to, for example, medical practitioners to come on site or have her taken to them. I've complained to you. You've told me my rights. I go, yes, I think they're being breached. You've said there's this range of processes. Me, with my mum in the home, what time frame am I looking at for you to do all these things before there's an outcome for my mum?
Senator, the additional information you have provided in relation to the immediacy and urgency of the need means that there is a parallel track here. Even as Ms McLeod and her team are dealing with the complaint and the complainant, there is a referral being made within the Commission, and this is under the bill, to those areas which have the opportunity of undertaking a site visit on an urgent basis, on an unannounced basis, requiring additional information from them, which Ms McLeod may have initiated or may be initiated elsewhere in the Commission. We move quickly.
How quickly? That's what I'm asking you. Is
Literally,
it like tomorrow? Is it next week?
If our concern is heightened in the way that you've outlined it there, we may send a team out this afternoon or tomorrow. It doesn't matter what day of the week it is. If we have an immediate concern for the well-being of one or more individuals at that service, we will act, and we will do so quickly.
And that is happening now? Because
yes.
I guess that's
and
one
that
of the concerns
continue to happen
is
under
that
the new Act.
Consumers are saying they're feeling like complaints aren't being acted on.
It does go to the degree of urgency of need. The vast majority of complaints that we receive are not matters where an individual's health is in dire jeopardy. They are concerns about the quality of the care, the nature of care, the timeliness of the care. These are legitimate and important concerns.
All right, so let's say my concern then is about timeliness of care. What's the time frame that I would expect for that to be investigated and someone to come back to me and for action to be taken?
So we would, Senator, be assessing, as I indicated, based on risk. So if it's about the timeliness of care, so for example, missed medication, for example, we would be getting that initial triage, we would be getting in contact with the provider within a matter of days.
Mm-hmm. Okay. So you've talked me through, Ms McLeod, to the point where I've contacted you, you've potentially sent someone out to have a look, you've advised me of my rights. If things aren't improving, what's the next step?
Well, I'll let the Commissioner answer because we're talking about her area.
There is some parallel tracking here because the ongoing relationship between the Commission and the complainant now and under the new Act is vital. And that's something that we take very seriously, and there are staff who are very expertly trained in ensuring that relationship is ongoing. And
so am I given a case manager or something like that? Do
yes.
I have one point of contact
yes.
who I'm talking to the whole time?
Yes, Senator. So you'll have a designated complaints officer who is dealing and ensuring that you and your loved one are kept updated with what's going on along the journey of the complaint.
Okay, and that starts with you, Ms McLeod, or your office?
Yes.
And then there's a parallel track where it's advised across to the aged care quality and safety.
Yes.
Let's say, Ms McLeod, you determine that there's a remedy that needs to be implemented. How does that work?
So depending on the nature of the remedy, the complaints officer will remain in contact with you as the complainant, while the other actions going on in the rest of the Commission around concerns about compliance with the quality standards, with the statement of rights and the like, is those parallel activities are going on. And it's the job of the complaints officer to keep you updated with those about what parallel activities are going on. So say, for example, it's concerns about a worker that you have raised and the care being delivered by that worker. That may trigger us to have a look at the code of conduct, and that may invite the parallel processes in terms of investigating the circumstances around the worker and the care that has been provided. And so, whatever it might be, depending on how serious or egregious what has unfolded, it might result in some form of outcome such as a banning order at the highest level, or it could end up being a caution letter, a reminder of responsibilities, things like that. But at all times, you will be in contact with the designated complaints officer, so you're brought along that journey.
Okay, you'll have to excuse me. I mean, I'm very much conscious of the fact that all of us are going to have to deal with this system at some point. I consider myself to be a reasonably intelligent person, and yet I'm still not clear if I have a parent, once I've raised this process, who decides what the remedy is? Is it you or the aged care quality and safety, or is it both? And then my next question will be, once I understand that, is how is that actually enforced? And I guess one of the things that I'm struggling to understand is we're talking about a system where if I had any other service being provided to me, I would be protected by consumer law, I would have individual rights that I could pursue. When I read the provisions in the Act, those seem to be, they're expressly excluded. We're asking people to potentially be paying a significant increase for a service that they're receiving, but it seems to me that it's still not clear what recourse that individual has if things are not done correctly, and secondly, whether it's just a systemic response as opposed to actual redress for an individual who has experienced harm, whether that be psychological harm because they don't feel safe because things aren't being done, notwithstanding they might not be at immediate risk. So, yeah, if we could maybe backtrack to the who decides the remedy and how is it enforced, and whether that's a systemic response or whether there is any ability at all for an individual to have recourse for recompense or redress for the harm that's caused to them.
Okay. Senator, part of what we're struggling with here is the complexity of the individual example versus the general case. And the difficulty we have is it's problematic to generalise because we are dealing with the presentation. Whatever the circumstances of a particular issue is what we are responding to, which is why we're struggling to provide answers to a question which keeps changing subtly.
Well, let's just go back to my original one.
Yeah.
Pressure sores not being dealt with, mum's at risk, I've complained,
all right,
nothing's being done, what are we doing next?
Well, I wasn't sure about the complaint, nothing's been done. So you have had that interaction with the provider and they seem unresponsive, so you've come to us. We take that complaint. You become the complainant with a case manager dealing with that case. If they then have a conversation with the provider, if there is no immediate risk, which can be assessed today, then let's deal with that. Then they have a discussion with the provider and say, we have received this information on behalf of this complainant. What say you? What are you doing? What is the circumstance? You must give us information, and we can require that under the new bill. We can require that information in a particular time. You must give us information about the circumstances and your response to these allegations, and to the extent that they may be true, and we're still discovering that, what you're going to do about it and how quickly. So they have to tell their side of the story, which is only fair.
Yep, due process.
But depending on the urgency, we might require them to do that really quickly. Now, the adequacy of their response is something we then assess. 9 times out of, I won't exaggerate, the majority of the time, a complaint is solved within that interaction. It may take a couple of goes where we go back to the provider again for further clarification after that information is communicated to the complainant. But in most instances, the complaint is sorted, resolved satisfactorily through that interaction. But there will be, and it may be that this set of circumstances qualifies, it will be that there are some situations where there is evidence of non-compliance with an obligation, or with the quality standards, or with a condition of registration, or with one of the obligations in relation to the statement of rights, where I will either require more information or, making a finding of non-compliance, move to an enforcement.
Okay, and how does that play out then?
Well, again, it's based on the evidence. It's based on the extent to which they are in breach of an obligation, or how many obligations, and also what their response is when I put that information to them. If they are already working on addressing the problem and are making really good progress, then my disposition would be to monitor them, because voluntarily they are doing what is required of them. However, if there is an unacceptable failure in care, I will move to enforcement nonetheless.
What's an unacceptable failure?
It's difficult to be specific about it, but I think that the common sense meaning of that term is that it's foreseeable, it should have been anticipated, and it should have been prevented. And yet it happened.
Because does that mean serious enforcement can't happen until something goes catastrophically wrong?
No, it doesn't, Senator. But we are a risk-based proportionate regulator, and indeed that is written into the bill, that expectation that our preventative action and our responsive action is calibrated to the risk and the adequacy of the control of that risk and the existence or the risk of harm. So these are all variables in the mix. And in order for us to be effective, Senator, if I can just start from first principles, the reason you have a regulator is because there are some people who aren't getting it right. If everyone was getting it right all the time, you wouldn't need regulation, but they're not, because risk is inherent in the delivery of care. So a regulator holds the providers to account against a set of obligations and requirements. And our job is to incentivise high performance. And we incentivise it through carrots and sticks. And we use the carrots as far as they are delivering the right result, but we will always reach for a stick if a provider is at all lacking in capability or interest or willingness to address the shortcoming.
And what are the sticks? What are the options? And is it the Aged Care Quality and Safety Commission under this bill who meters out the sticks?
Yes, it is.
And what are the options available to you under this ledge?
There are many of them. Let me go to my list. The two primary tools are a required action notice, and then a more serious tool is a compliance notice. Now, I'm
just conscious of time.
Okay.
So I guess if I come to the nub of my question, there's been an action taken against a provider appeals, there's no minimal outcome. What is the ultimate recourse for the person who's experienced the harm in that situation?
So, Senator, for the individual, there are a number of tools we have in the complaints process that are available to us. So it might be that we think and we do this in discussion with you, that we think it's appropriate for there to be open disclosure. So the provider explaining what has happened and why, making an apology, and their commitment to how they've, what they're doing to fix the situation and prevent it from happening again. Other options might be to conciliate between the complainant and the provider and get an agreement, and that conciliation is by the Commission, and get an agreement between the older person or the complainant and the provider as to what's going to happen from here on in. Under the bill, we're also looking to introduce a restorative engagement conference where there's that opportunity to be able, if you're a complainant, to have, the provider acknowledge the harm that has been caused, and listen to the experience of the complainant, the older person, and ensure that that experience is validated, and that they're given an opportunity to hear what further the provider is doing to ensure that that doesn't happen again.
Okay, I'm conscious of time, so I'm going to go back to the chair, and if there's time at the end, I might clarify a little further. Thank you.
Thank you very much, Senator Allman-Payne. I'm passing the call to Senator Ruston.
Thank you very much. Could I just ask, are the strength and quality standards that are on the website listed as final draft November 2023 the most up-to-date standards that are available, and are they reflective of the final standard?
Senator, that probably is a question more properly directed to the department.
Okay. So in relation to those strength and quality standards, I'll assume that the ones that are at November 2023, because I can't find any others, how does the Commission measure an increase in the quality of care that is delivered by a strengthening of a standard?
Sorry, Senator, can I just clarify your question? So you're contrasting the existing standards with the strengthened standards, and then asking how we would evaluate whether there's been a change in the performance of providers?
Yeah.
Okay. We have done a lot of work on examining the new standards, unpacking them, and in particular looking at our evidentiary sources to assess the performance of provider against those strengthened standards. And Senator, we've published guidance on this to the sector, which has been out now for at least 6 months as draft guidance, and it's a very substantial document which maps through for each outcome within the new standards what the sources of evidence would be that would enable us to assess their performance. And that's probably the source to which I would direct you.
Yeah. So I'm sort of keen to understand in terms of that, because I obviously read this draft standards, and I mean there is a really comprehensive piece of work there in terms of a whole heap of expectations in the various categories of standards. How do you go about mitigating against the risk of over-regulation, which potentially has the ability to impact on the quality of care in a negative way, at the same time as trying to make sure that that they're fit for purpose? Because in reading through that, I mean, I'll have a look at the document that you've just referred me to. It seems like there is just this extraordinary level of requirement in terms of dealing with risk in terms of these standards, and I just wonder how you approach that in terms of delivering the actual care and measuring the care for the individuals against the need to comply.
Yes, you're right that the strengthened standards have a certain weight to them, and the architecture is the base standard, and then outcomes and then actions. We regulate against the outcomes, which is the intermediate level. with regard to the actions. So we don't go to individual actions, which is where you get that precise detail within the standard. We go next layer up, which is outcomes, but having regard to the various actions which inform that outcome. So in that step alone, we have moderated the intensity of our gaze in some ways, but we still believe, and we've tested this, that looking at performance from an outcomes perspective gives us sufficient information about performance in order to reach a view about conformance.
Yeah, so taking that one step further, so in terms of the actual measurement of the increase in the quality of the care to the individual, do you actually, within the frameworks that you've got, have a capacity to actually provide a measure of that? You know, saying that patient or resident A or a home care recipient B have received a level of care that has been increased as a result of any of these changes and reforms. How do you actually measure the actual care increase or outcome increase for the individual?
We cannot do it with that precision, Senator, and I expect that is probably what you understood. However, I will say that we draw information about performance from a number of sources. It is not just our assessment of a provider against the standards, although that is really important. As you know, we receive information on serious incident notifications. We have the quality indicator data, which is reported, all the financial information coming through and other information coming through the quarterly financial reports. We are now maturing our risk engine in a way that hasn't been the case historically, which enable us to understand the performance of a provider and the services within that provider to a degree of accuracy and timeliness which hasn't been available to us. And I am fully confident that we will be in a position to assess relative performance over time using that full array of incoming intelligence in a way also that hasn't been available to us historically.
Yeah, just interested in, I think it's section 110. It references, in terms of providers' requirements, it uses the word conform when it refers to the quality standards rather than comply. I'm just interested in your understanding what the difference between conform and comply is.
I think we need the legislative drafters to fully embrace that question. But you're right, the language of conformance is used specifically in relation to our auditing of a provider against the quality standards, which contributes to our assessment of their eligibility for registration or renewal of registration, which is, as you know, that triennial process. If they are performing adequately or admirably, they will get around 3 years registration, and every third year we go back and have another look at them against the quality standards as part of a larger review of their performance to see whether they remain eligible for registration for a further period.
Okay, yes, who would ever understand the dark arts of drafting legislation? Back to the final draft that's sitting on the website in relation to the strengthened quality standards, are you aware or do you have any idea in relation to whether those are the same standards that will be defined in the rules?
Senator, as far as I'm aware, and the department will be before you soon enough to talk to this, as far as I'm aware, they are the current version, and they are also the version that we expect will be implemented on 1 July. Certainly there has been no other publication of which I'm aware. So that is the reason we have done so much work in preparing the sector for these strengthened standards in all of the guidance material that we've released so far, because our expectation on the basis of communications with the department is that those are the standards which will be enlivened by the passage of the bill.
Yeah. So can I just ask you, in relation to those standards and the definition of clinical care, that are contained in there in relation to doctors, nurses, pharmacists, allied health. They're the whole list of health professionals. Are you aware whether the definitions, as they rely on these quality standards, are the same for home care as they are, or the new supported home, as they are for residential aged care?
We have a single set of standards, Senator, so there would not be variation in those material matters.
Yep. Okay, fine. And just finally, and I just put on notice, Chair, that I've got a few questions for IHACPA as well. But just finally, in terms of your measurement of value, I'm interested to understand in relation to things like star rating system and the monthly reporting, whether is it your role in any way to assess whether these are actually delivering quality outcomes for residents or clients? Have you had an opportunity to look at these things to determine whether they are actually, for the amount of effort that's put into them, whether they're actually delivering the outcomes that they needed to deliver?
We're not doing a cause and effect analysis, Senator, but I think it would be fair over time to examine movements in levels of compliance across residential services and across home care providers, and to reflect on whether there might be a correlation or possibly even a causation that might be attributed to those sorts of moves. I still think it's a bit too early. I think there's a little bit of time yet to run while providers are becoming more used to complying with those provisions and looking to workforce supply performance more generally as something that we're taking very seriously.
Thanks. Do you want me to stop there, Chair, or go straight on to IHACPA?
No, Senator Ruston, you still have a bit left in this call, so why don't you continue? Louise has a few questions. I might need to put mine on notice, but we'll see how we go. But Senator Ruston, please continue.
Oh, okay, thanks. So have we got Professor Purban? Yes, we do. So I'm just wondering whether have you undertaken determination in relation to pricing for supported home from 1 July 2025?
We're in the process of doing that right now, Senator. We are coming to the end of our second costing study, which is giving us a lot more information around the costs of the delivery of supported home. We are providing information through to the Minister for MyEFO, which will inform budget and so on. But yes, we're on target to deliver prices against the service list provided by the department early next year.
Have you also been working on the nationally efficient price for CHSP?
No, that's still with the department. So
Okay.
Our advice doesn't kick in terms of pricing aged care services supported home aged care services until 1 July next year.
Okay. Okay, so in terms of how you've been determining these prices, do you feel that you've got sufficient information to be really confident about the robustness of these recommendations, given I understand aged care has only been recently added to the purview of your pricing analysis? How confident are you in relation to that information?
Thank you, Senator. I think this follows on from your question at the last estimates hearing. We are increasingly confident. The nature of the work we do means that we're never going to come out and say we are 100% confident, which is why we undertake repeated costing studies, why we put draft frameworks out for consultation into the sector, why we meet with stakeholders from the sector to get better information. For example, we had a fantastic meeting only 24 hours ago with the Australian Community Transport Association and a data exercise they're engaged with a local university, which we will draw from that as well as many, many other data points. So not just our costing study, but the data that the department holds around these services, independent data such as the set that I've just mentioned from Community Transport, as well as benchmarking across with the other similar services. I won't say they're the same, but similar services such as the NDIS and veteran services. So we get to a level of confidence where we are happy to present our recommendations to the Pricing Authority, our board, for recommendations on to the Minister based on all of those cross-checks and quality assurance measures.
Yeah. I mean, I suppose I'm just interested to understand, taking it down to its, sort of most basic level. So if we actually had a look at the national efficient price for, say, gardening or lawn mowing or whatever it happened to be, would we have the same price if we were NDIS, Support at Home, Commonwealth Home Support Program, Veteran Affairs? I mean, what is the capacity for a nationally efficient price for an action as opposed to where it actually sits, where it's been determined? So, I mean, in your case, you've got CHSP and HCP, which will eventually be Support at Home. Does your nationally efficient price for the same thing come out to be the same price depending on what program it's being operated under?
What you're referring to is what we would call price harmonisation, Senator, and it's something that we are...
You're much more eloquent than me.
It's something that we're actually very keen on for all sorts of very obvious reasons. At the moment, that's not the case, simply because the providers from those different domains, different sectors, provide different data as to their costs, and our methodology around costing the services based on costing data and external benchmarks is slightly different to that employed by DVA or by the NDIA. So until such time as we are all pricing using the same data, the same assumptions and the same benchmarks, there's always going to be that potential for price variation, but we do check and we do make sure that they are, comparable, if not in the realm for what we're actually purchasing for the same service, the same action, as to use your words.
Yeah, because I think probably, and this is often only anecdotal, but one of the things I would hear more often than not when you turn up to aged care expos, when you speak to people who particularly are getting services at home, they'll say, if they would have been quoted $200 for something that if you or I rang up and asked for it, we'd get quoted $70 or $50 for. And I just wondered, how that is happening. I mean, do you have a view around that? Because it is overwhelmingly what we get, that the price that people are able to be charged through packages is significantly more than if they rang up as Joe Citizen.
We do have a view, which is why we are interested in providing government with some recommendations around opportunities for harmonisation. And of course, the easiest place to start for those will be where we've got the most data. And so that will be in those comparable or identical services, such as home cleaning and some of those issues. But until we've got this next costing study done and we can have a look at that compared to what we observe in pricing for the other services that I've mentioned, we're not going to have a feeling for how much variation there is. I suspect for some of those services there's little variation, for others there's not, and I would be remiss if I didn't say that there are some instances where services may appear to be identical but require more time, more expertise, cleaners to be trained in infection prevention and control and so on. So there's still a bit of investigation to be done, but the benefit in the process of getting the cost data from the providers and using all those benchmarks is that the services are maintained while we're doing that investigation, getting that understanding and getting smarter about the way we price government-funded services.
Yeah, thanks. I'm assuming from the answer to your previous question that you haven't provided the government as yet with your pricing recommendations for Support at Home?
No, not yet. As I said, we're still working on those.
When do you think that's likely to be completed and available to the government? When are you likely to report to the government on it?
Once again, that's a government decision. We're just an advisory body, but our plan.
No, but when are you going to report to them? Not when are they going to do something with it? When are you likely to be in a position to be able to provide them with your information?
Thank you, Senator. Early next year is the work program.
Okay. Thank you. Thanks, Chair.
Thanks, Senator Ruston. Senator Pratt.
Thank you, Chair. I've got some quick questions, please, around digital platforms inside the new system. I'm aware that there are concerns that some providers are already doing corporate restructuring in aged care to in the in-home aged care sector to avoid regulations, and that they're doing this by streaming people who are covered by regulation into new wholly owned corporate entities so that their remaining caseload can stay outside the regulation, because regulation's not required for everybody. I'm interested to hear from IHACPA about what pricing implications there are for these kinds of issues, and also from the Aged Care Quality Safety Commission. Surely we don't want to see restructuring like this when we're trying to strengthen the whole system.
Okay. Thank you, Senator. Part of the reason why we base our pricing advice on costing data, costing evidence, is that as much as some providers can get very adaptive in how they respond to new regulation and new systems, the costs are the costs. So as well as more creative providers, I'm struggling to describe that scenario you've just laid out for us, we will get information from across the sector, from very, very small providers in very remote areas through to the big commercial or for-profit providers, so that we get sufficient data from across the sector that we're confident that the prices are reasonable, represent value for money for government, and support the services to be provided. Beyond that, as much as it's a fascinating practice or scenario you've just laid out for us, it's not an issue.
I would suggest.
Health and aged care service providers are very highly adaptive to rules, regulations, pricing formulae. It doesn't matter whether it's private or public sector. They've demonstrated great creativity, which is why we lean on the data.
Context, what information do you use to inform pricing advice? What consultation do you use for pricing advice? And how do you ensure that it's independent pricing, particularly for the new Support at Home program, and how you're pricing that and the way it differs from the current in-home care packages?
Okay, thank you, Senator. I could actually talk until this evening to answer your question. I don't think anyone would thank me for that. I could ask you to have a quick look at our website, where you'll see the pricing framework, the discussion paper for pricing Support at Home. That actually goes through in great detail the answers to your questions. So it's all there, as well as
to do that.
Sorry, Senator, as well as the results from the first costing study. So part of our practice is to actually publish not just the price, but the data that we've gathered, what that means, what it tells us, and then follow that up with a pricing framework that first of all is issued in draft to the sector and to the public at large, that maps out the issues that we will consider in pricing, gets that feedback after 45 days is our standard practice, and then we'll develop both a pricing formula based on that data that's already been out for consultation. So we have multiple levels of validating the data and our processes, and then when we issue a price, we also will publish that as well as the way we've calculated it. In addition to those big headline kind of consultative and engagement processes, we meet continually with stakeholders, both peak bodies and individual providers, and welcome that kind of input and direct engagement. It's what gives our stuff some meaning, and particularly for our staff, gives them an understanding of the impact of the advice that they're giving.
Okay. In that context, what's your role in approving residential aged care room prices above the legislated maximum, and why is that important? And how will you manage that increase in the maximum room price, which I understand is up to $750,000 from next year? Up
from $550,000, indeed, Senator. So that's a function that came to IHACPA around 2 years ago, when we were IPA, in fact. And so the process is very, very detailed and very well laid out in documentation. It requires a provider to apply to us in our role as the taking over from the former Pricing Commissioner, the information that is required to approve refundable accommodation deposit above the limit is expansive. And it goes to the details of the size of the room, the features and fittings, the joinery, the carpet, the amenity, whether it's got a balcony or not, how big that balcony is, etc., etc. So an assessment is made based on the evidence by a small and very expert accommodation team that just work on these applications. And they work on them as quickly as they can and either recommend acceptance or rejection. More often than not, though, to revert to the provider for more information. And there are time limits around the process, both on us and on the provider, so it's not something that lingers on indefinitely. The other thing I think that is important to point out is that it would be very rare for a provider's entire facility to be, a RAD above now 750. Those RADs above benchmark apply to, in most cases, a small number of rooms or a suite or a facility in a bigger facility. And while the ceiling has been lifted, and that's been recommended in the very excellent Tune review of some years ago, it should be noted that a lot of facilities don't charge the $550. They're especially the rural ones, they're down significantly lower.
Some quick questions for the Aged Care Quality and Safety Commission. Can I ask, firstly, what's in place to support the sector to transition to the new framework under the new Aged Care Bill, and how's that going?
Thank you, Senator. There is a great deal of work being undertaken between ourselves and the department, a very extensive campaign providing guidance, as we've talked earlier, about the strengthened standards, but also about matters relating to registration. Now, the department is leading that work, but the Commission has an obligation to establish the register, which needs to be going live from 1 July. So there's an enormous lead up to that for work that we're doing internal to the Commission to ensure that we're ready. The communication strategy, though, is something, as I said, that we share with the department, and that is going to be a singular and really important piece of work, to ensure that providers are aware that from the 1st of July they will be registered, that there will be a deeming process, and that they need to start participating in that process as soon as it's launched by the department, in order that they can be squared away and operating with the right sort of registration from day one. So those are the key pillars: the registration of providers and their understanding of their obligations, and that is the subject of the communication strategy that we're pursuing with the department.
And do you think providers are ready? To me, they seem to be, along with consumers, very keen for the new Act to be implemented. So I guess I'm keen to see how you think that's going, and to ask you about the importance of the Complaints Commissioner being independent from you as Quality and Safety Commissioner.
to your first question, Senator, yes, I have the same sense of growing anticipation. We had a national conference earlier this year, and the vibe was one of cautious enthusiasm. They are very interested, engaged. I think there's an increasing level of attention being paid to the details and what's expected of them. They are asking really important and good questions about transitional arrangements, and these also must be answered across coming months. So I think we're well placed. I do think there are leaders and laggards, and we're going to have to find the laggards and bring them along because we can't afford to leave anyone behind. In relation to your second question, Senator, the bill does something very important in establishing the distinction between the role to be performed by the Complaints Commissioner and the role that I hold. As agency head and accountable authority, the position I currently occupy will have responsibility for the agency as a whole and everything that occurs within that agency. But really importantly, and you heard it from the Acting Inspector General, what consumers and complainants want is a sense of certainty, a trust that the regulator is going to be listening to them, to their voice, to their concern, and responding and engaging with them to essentially support them to achieve the outcome they want from aged care or for their loved one. And the establishment of this discrete role within the Commission is the best of both worlds. It ensures that there is that very unique and singular channel and somebody whose attention is dedicated to addressing the issues which are raised by complainants, and alongside them, all of the panoply of powers for compliance and enforcement which go to the provider as an entity, as an operating entity, and sees them in the complexity of their risk profile and how capably they're managing it to ensure that they're delivering first-class care to every single older person.
Thank you, Commissioner, and I'll have to leave it there due to time.
Thank you, Senator Pratt. Look, I believe there'll be some more questions coming to you on notice. I know I have some. I didn't get a chance to ask any. So we'll be placing them to you, and we're asking for answers to be returned to us by close of business on Thursday, the 10th of October. But thank you very much for your evidence today. The committee will now suspend, and we will be recommencing at 1:30 Eastern Time. Thank you very much. And I welcome representatives from the Department of Health and Aged Care, including the National Aged Care Advisory Council, the Aged Care Council of Elders, the Aged Care Task Force, and the Interim First Nations Aged Care Commissioner. Thank you for appearing before the committee today. The Senate has resolved that an officer of a Department of the Commonwealth or of a state shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or to a minister. This resolution does not preclude questions asking for explanations of policies or factual questions about when and how policies were adopted. Commonwealth officers appearing today are also reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised. A copy of the order is available from the Secretariat. For the Hansard record, could you all please state your full names and the capacity in which you're appearing today, and I'll let you choose your own order in the room. Thank you.
Thanks, Chair. Michael Lai, Deputy Secretary of the Ageing and Aged Care Group in the Department of Health and Aged Care.
Amy Laffin, First Assistant Secretary, Quality and Assurance Division.
Mel Metz, Assistant Secretary, Legislative Reform Branch.
Thank you very much. Do any of you have an opening statement you wish to make?
Yes, Chair, I do.
Thank you, Mr. Lai.
So I'd like to start by thanking the committee for the opportunity to appear before the inquiry into the Aged Care Bill. It was introduced to Parliament on the 12th of September 2024. The bill brings together work on the new Support at Home program, recommendations of the Aged Care Task Force, and responds to around 60 recommendations of the Royal Commission to Aged Care Quality and Safety. The bill responds directly to recommendations 1 through 3 of the Royal Commission. If enacted, it will establish a new legislative framework for aged care with clear objects, rights and principles that centre around the needs of older people. It provides unambiguous eligibility criteria designed to target aged care to those who need it and, consistent with the Royal Commission's wishes, prevents younger people from entering aged care. It also supports the new single assessment process and aims to make the process of assessing needs transparent and fair for older people. The bill brings together the funding and regulatory arrangements for multiple existing and new aged care programs, including residential care, the Commonwealth Home Support Program, the National Aboriginal and Torres Strait Islander Flexible Aged Care Program, the Multi-Purpose Services Program, the Transition Care Program and the new Supported Home Program. Supported Home aims to provide improved access to supports and services to help people remain independent at home and higher levels of care in the home so that people can remain home for longer. The bill enables fair contributions for those who can afford to contribute to the cost of their care, which are based on the recommendations of the Aged Care Task Force. The aim of these reforms is to ensure that the aged care system is financially sustainable into the future as the population ages. The bill also introduces a new approach to regulating aged care. The approach provides incentives for continuous improvement and high-quality care while introducing strong regulatory powers to protect people from harm. Following the release of the Royal Commission's final report, the Department has actively consulted on the reforms included in this bill. This includes consultation on the regulatory framework, the quality standards, worker screening and supported home. In 2023, Minister Wells established a task force to review funding arrangements for aged care and develop options for a system that is fair and equitable for everyone in Australia. The outcomes of this work are reflected in the bill. The Department also consulted specifically on the design and delivery of the Aged Care Bill. The first engagement in August and September 2023 focused on the core components of the rights-based framework. Then, from December 2023 to March 2024, the Department consulted on an exposure draft of the bill. We received over 320 submissions, more than 800 surveys and heard from more than 10,000 people at our webinars, workshops and roundtables. This feedback helped us to shape the bill introduced to Parliament on 12 September. It is worth noting at the outset of hearings that we're very aware of the high level of interest in the aged care rules. The rules can only be finalised and tabled following passage of the bill, and they will be subject to disallowance. This committee process and changes made during the passage of the bill will need to be considered in developing the rules. Rules development typically follows development of primary legislation for this reason, and because the primary legislation sets the parameters of what can be included in the rules. This is not uncommon. The Royal Commission Response Bill was considered by this committee in 2021, and the rules that accompanied that bill were developed and consulted on following passage. The current aged care principles and rules made under the Aged Care Quality and Safety Commission Act are in the order of 900 pages. We anticipate that if the bill is passed in its current form, the rules made under the new Aged Care Act will be of a similar size. The Department has been through a rigorous exercise to identify where rules are required, how these are scoped and sized, and is sequencing their development with the Office of Parliamentary Counsel. Some rules are new, for example those relating to supported home. Others will largely replicate what is in current subordinate legislation, for example rules relating to the Serious Incident Response Scheme and ANAC. As the aged care rules contain operational detail, drafting will take time, and stakeholders will also need time to consider them before they are finalised. While it's difficult to commit to providing a defined set of rules by a given time, due to the complexity that can arise during drafting, we have released the service list and we are prioritising the development of rules for Chapter 4 relating to subsidies and payments. Our intention is to have as many rules as possible for Chapter 4 ready to support this committee inquiry process with a view to providing them in mid-October. Recognising we are unable to provide draft rules for Chapter 4 before the hearings, we will provide the committee with an overview of the scope and high-level approach for these rules in the week commencing 7 October. The Minister has made a commitment to publish and consult on the rules in stages. Our intention is for the consultation on the rules to be commensurate with the level of significance. This will range from publishing for comment and submission on the Department of Health and Aged Care website to more interactive approaches such as webinars and roundtable discussions. In summary, the rules will not deviate from the policies and exposure draft already announced to the public. At the same time, we're also developing a consequential and transitional provisions bill, which will provide for transitional amendments to ensure existing arrangements and services continue or transition smoothly into new programs such as support at home. The bill will bring current providers under the new registration and regulatory framework and older people under the new approval and assessment framework to ensure continuity of services when the aged care bill commences. It will also provide for the transition of governance arrangements and provide for grandfathering of individual contributions to the cost of their care and implement the no worse off principle. We've come a long way since the Royal Commission handed down its final report in 2021, and we have much more to do to make sure that we get the aged care reforms right. The feedback from this committee and the views you ascertain through the hearings are important to us, and we look forward to implementing the reforms that the bill will enable. We look forward to the committee reporting on its findings.
Thank you, Mr Lai. I'm going to pass the call to Senator Ruston.
Thank you very much. Hi, Mr Lai, how are you?
Good, thanks.
Good. So you've obviously given us quite a detailed explanation around the timeframe the challenges that you face in providing the rules, which are obviously of significant interest to many people. I'm just trying to get some sort of understanding from what you've just said. When will we see the rules, and what rules will you anticipate that we will be able to see during the process, the timeframe of this committee's hearing duration?
Senator, we're prioritising Chapter 4 related rules, as Mr Lai outlined. It's unlikely that the full scope of Chapter 4 rules will be available for the committee, but we are looking to prioritise some parts of the Chapter 4 related rules and have them available in mid-October. We understand that's not ideal, so what we are doing is providing an outline of what those rules are going to cover, and we plan to provide that to the committee next week.
So, in terms of the drafting instructions that have been provided to Parliamentary Council so far, how many of the rules that are referred to in the bill have had drafting instructions issued for them to date?
Well, we've obviously issued instructions in relation to the service list, which is now available for public consultation. Instructions for all of Chapter 4, aside from some programs, transition care program and multipurpose services program, have been provided to OPC as well.
Okay, so in the bill, there's like 260 plus references to the rules, and of those, in excess of 200 are sort of prescribed areas. So appear, from what you can tell from the bill, to be unique in terms of what they're asking for. In your opening statement, Mr Lai, you made reference to the fact that some are new rules and some replicate what's in existing legislation. I was just wondering if you could give us a bit of a breakdown as to how many of these, in excess of 260 references, and certainly more than 200 sort of defined elements around the rules, are new rules.
Thank you, Senator. Greg Keane, Assistant Secretary, Legislative Reform Branch. So we're working with in the order of about 60 rules topics. Within those topics, they will relate to several provisions. We've done an assessment of the degree to which they are existing or new, and about 2/3 are existing in some form, and 1/3 that will need to be developed with quite a bit more work. Even those that are existing still require sort of some adaptation to reflect what might be new in the bill, and of course to put them in that current context.
So in effect, probably about 1/3 of them are substantive in terms of their newness. Is that what I'm taking away from that comment?
That's correct, yes.
Okay. Have you prioritised in terms of your drafting instructions the new rules?
So we've prioritised the development of rules across 6 tranches, and in that prioritisation we've considered a variety of factors. The new rules are spread across each of those particular tranches, so it is dependent on sort of particular areas of focus. I can give you a breakdown, if you like, of across each tranche the degree to which they're new or existing.
That, I mean, you don't have to do that now, but I'd be interested if you wanted to flick that to me. What I'm trying to understand is that there seems to be, some rules that probably could quite easily be sort of any concerns immediately ameliorated because they are largely functional or existing, and there are clearly some quite significant rules that will be, quite significant in their impact on how people respond. Like we're asking, people in relation to whether it be providers, whether it be the responsibility of people who are representatives and the like, they refer to the rules, but what those rules actually are, is going to be quite significant around how they respond to it. So the timing of receiving that is going to have quite a significant impact on the transitional arrangements that are in place. It's all well and good for us to get this bill passed this year, which obviously we're all working very hard to do. But in the absence of knowing what the rules are, it's really quite hard, both for providers, for older Australians, for the people who are advocating, representing them, to actually understand what they're doing. So it would be really helpful to try and understand when the rules that are really going to impact on people's responsibilities, obligations, particularly things that they, in the terms of providers, that they potentially could be liable for in terms of their responsibilities to provide high quality care to older Australians. That's really where we need to understand what the rules are. So just to what extent are the rules different, like in terms of how they're applied from existing legislation? The degree of difference, like for instance, will the code of conduct be different in the new rules than the old rules?
Senator, I can answer that specific question about the code of conduct. So it's largely the same. However, when we transition existing rules into a new legislative framework, the language and terminology that's used obviously needs to be consistent with the new framework. So there might be some changes of that nature, but no changes that represent a change in policy. We're very happy to give any information to the committee about the different aspects of the rules that may be of concern and what's going to be covered in them.
Well, I don't know what's of concern because I don't know what the rules are.
Senator, without undercutting the importance of the rules really operationalise the policy, and I suppose the point in the opening statement is that we have on all the elements that are contained in the bill itself, the policy is available, and we've consulted extensively on most of that policy. And so, yes, we all have to be diligent, I think, and it is important to look at the rules when they're drafted and make sure that they appropriately operationalise what we thought the policy was. But there are no surprises from our point of view in terms of they will be faithful to the policy that's been announced by the government.
Yeah, sure. And look, I absolutely respect that, but as we all know, the devil's in the detail. So is in terms of, there's obviously quite a complex maze of legislation and regulations that exist at the moment that operate. Just wondering, in terms of existing subordinated legislative instruments that are in place at the moment, is there an understanding about, how much of that is likely to change in terms of those regulations, and when are we likely to see that? Because clearly, if you put in a whole new act, there is going to be a whole heap of subordinated instruments, regulation and the like that is in place at the moment that will need to change to reflect the new act. Just sort of keen to understand when that process is likely to occur.
So it's part of the process of drafting the rules, Senator, that we're transitioning all of that existing legislation over where it's relevant. We've done a very detailed mapping exercise of the existing both primary and subordinate legislation to understand exactly what needs to transition over.
So in terms of that, what I'm trying to do is sort of like in my own mind map how we get to the 1st of July next year and be in a position where this transition is going to be as effective as it needs to be, but also as painless as it possibly can be, understanding that all reform has its own challenges. So what is the latest date that providers will be provided with the necessary information that they will need to make changes within their organisation in order to meet your requirements for the 1st of July? Or is there going to be a period built into the when the new Act comes in on the 1st of July to give providers 12 months, say, for instance, to get their systems up and running? So what are the transition provisions that have been considered as part of this process?
Yeah, so a lot of that will be set out in the Consequential and Transitional Bill, Senator. That bill is going to cover primarily how individuals transition over into the new system and how current approved providers and other providers who will need to be registered under the new system become registered providers. And we're looking to make that process as streamlined as possible through those legislative provisions. Particularly with providers, we will be deeming them across, and we'll be shortly undertaking some work with providers about exactly how it is that they are deemed across. I think we've got information on the department's website about that process at the moment. So all of those things will require a lot of engagement and work with the sector.
But for example, on those deeming categories, we'll start off with a small pilot and branch out, but we expect that most providers will have an understanding of their future registration category by the end of this month.
Okay, so you talk about the transitional bill. Was that introduced at the same time as the bill?
That will be introduced later this year, Senator. So it covers those transitional matters and also all of the consequential changes across the statute book that require references to aged care legislation to be updated.
When you say later this year, will we be able to see that before we are asked to vote on the bill?
I can't answer that question, Senator. That's not, the department doesn't determine when the votes will occur.
Will we see this before November?
It's planned that it will be introduced in November.
Can we now just move to the supported home design? You got the right people there? Sorry, I can't see
Hopefully,
very
Senator.
much here, so
Yeah.
let me know when it's time.
If design not means testing.
No, the actual design of the package.
Yeah.
I'm just interested to understand what the design process was in relation to the service list that you just recently published. What the process was for in order to do that.
Yep.
Senator, it's Nick Morgan, the Assistant Secretary for the Supported Home Reform Branch. The process we went through around the service list started from the existing services that are available through CHSP home care packages. We put together a survey that went out to the public some time ago now, I think around 2 years ago, with a draft list of services. We got feedback through that survey early on. Subsequent to that, we consulted with I believe the Council of Elders, as well as the National Aged Care Advisory Council on a draft service list. And I think they were the kind of key points. The service list was also considered by the Aged Care Task Force, and the categorisation of services in the service list was something that was, finalised on the basis of advice of the Aged Care Task Force.
So, in terms of the Aged Care Task Force that you just referred to, there was certainly they'd listed the categorisation of care, independence, and everyday living. Did I miss something? I don't think I saw anything much in there that actually referred to what should be included. I'm sort of more interested in understanding in that service list the detail that you've gone into as to what's included. Just as an example, as a question, how did you decide on the hours for the cap hours for cleaning, as an example? What was the process that was involved in that?
Well, I think the process that arrived at the caps on cleaning and gardening was really developed through, advice to government and government decisions on the program. We consulted. We had a consultation paper out, I think, back in 2022, which foreshadowed the possibility of that. So as we were consulting, we had a discussion paper and received feedback on those sorts of things, but the determination of the actual final hours was a decision of government.
Right. All right. Okay. So to that end, what was the basis then for the determination for the 10% cap on package management? Is it the same process and also a decision of government?
Well, it was a decision of government, but we did consult with service providers and others around care management.
You did or you didn't? Sorry.
Oh, we did. We had a number of discussions. The 10% care management equates to somewhere in the order of an hour a month for someone on the lowest level of supported home, up to somewhere in the order of 6 hours a month for a person on the highest level of supported home. But the way the fund was determined after consultation with providers was to have a pooled fund effectively for a service provider. So across all of their client base, 10% of all of their clients' budgets is pooled, and a service provider can draw down on that funding. So they'll invoice after care management is delivered, but has flexibility about how the care management fund is used across their clients. And that was really to reflect the fact that it's lumpy. Some people when they first start need more, or when something goes wrong need more, and in between times may not need as much, and it's hard to predict who and when. So that...
In that, so you refer to it as a 10% cap on package management. I'm just keen to understand the view of the department in relation to the difference between package management and care management, or are they interchangeable terms?
Sorry, I don't know if I said package management then. I would have misspoken. I was talking about the care management component. So a participant's budget, 10% of that budget is set aside for care management. So that's the provider supporting a person with their care planning.
And it's not a cap, it's pooled in a sense.
Yeah.
Yeah.
Yep. Okay, thank you. Okay. So in there's on your website you've got about the new bill regulatory environment sort of information page, and in there is a reference to CHSP and NATSFAC being contained for the first time in this bill. Can you point to me where in the bill those two programs are referenced in the bill?
They're specialist aged care programs.
So that's the extent of the reference, is it?
There's a definition, yes.
Okay. So in this, in the bill, there is no further provisioning or understanding as to what that might be. So how do I find out if I'm on CHSP at the moment, for instance, where will I find information as to what that will look like going forward?
Thea Connolly, First Assistant Secretary, Home and Residential Division, Senator. So the CHSP will largely continue as it is, as a grants program administered by the Commonwealth. There is limited information in relation to what that will look like under the New Aged Care Act at this current point in time. We recognise that. However, we are starting our engagement with CHSP participants and with providers, including with some outreach on the 22nd of October, where we will talk to people about how the CHSP will operate under the New Aged Care Act. As I said, it will largely continue from a client's perspective very similarly as it is at the moment. There will be some changes that we're anticipating talking to people about on the 22nd, in particular around service list arrangements. We'll be looking to align the service list more closely for in-home care across both Support at Home program and CHSP, where it's appropriate to do so. As I said, we're looking to minimise the impact on clients at this current point in time, noting that government's agreed that CHSP would not transition to Support at Home before 1 July 2027. So we're not looking at major changes, but we are looking at incremental changes to smooth the transition if and when it does come from 1 July 2027.
At this point, Senator, we'll just seek to rotate to Senator Allman-Payne in the room, but we will be coming back to the opposition. So Senator Allman-Payne in the call.
Thank you.
Thanks, Chair. Following on, I guess, from some of Senator Ruston's questions about the rules, I'm just wanting to get some information maybe about the assumptions or the ballpark figures that you've been working to. So if I start with the daily means test, and I note that that's section 319, are you able to talk us through? So if I go through that section, it talks about the first income threshold, the second income threshold, and so on and so forth. Do you have ballpark figures for what those thresholds are?
We should have that.
Nick Hartland, Special Advisor. So a couple of those thresholds have been included in the fact sheets that the government has published about the new program. The threshold, we will need to do a quick reconciliation about which.
So I'm conscious of time, so I guess my question is, have you already published the income thresholds, the first to the fourth, and then the asset thresholds?
Yes. So I just need to do a quick reconciliation.
Or you just want to know that they're publicly available?
Well, is it possible for them to be provided to the committee? Happy to get them on notice, but that would be helpful for us to consider the legislation.
So a couple of those thresholds already exist, but yes, we can give them. And the other thresholds are the ones that are mentioned. So they're a combination of existing thresholds which apply to accommodation supplement and the free areas, and the thresholds that were published in the fact sheet on residential aged care means testing. But lining them up with 1, 2, 3, 4 and those other thresholds is a bit of a chore, so we can give you a little table.
That'd be very helpful, because I'm conscious of the fact that we've only got a short time to inquire into the bill, and if we've got to go trying to hunt for information. So in terms then of the individual contribution amounts, are you able to give some insight onto the policy behind that, how the percentages were arrived at? And I guess what I'm interested to know too is, so if I go to something like Support at Home, where it talks about the contribution range, you know, it says independents will be 5 to 50%, 17% to 80%. Do you have the modelling that shows what you're working off to determine how much of a percentage each person is paying in each of those categories?
We could give you, Senator, a table that sets that out some people, full pensioners are paying a fixed percentage amount across those three categories. Obviously nothing against the clinical care category. And then people who have graduating levels of means are paying in that sort of 5 to 50% sliding scale. So a little bit, the percentage goes up obviously as your wealth goes up.
Yeah, and so we could give you those sliding scales so we can
I think we could give you a sliding scale. Yeah.
Senator, the overview that we plan to provide to the committee next week has that information in it.
All right, that would be very helpful.
The government has published some cameos of examples of people's
I've
contributions.
seen those, but it's very difficult from our perspective to look at the legislation and then try and work backwards from case studies to work out what's actually being used. So if we can just have those, that would be really helpful. In terms of, so in relation to the basic daily fee, is that 85% of the basic age pension, or is that going to be stipulated in the rules?
The amount is in the rules, but the policy is that it's 85% of the pension, and of course whenever the pension changes, that amount changes. So it's one of the figures that we update regularly.
And is that a single basic rate for everyone, or does that change based on whether they're single versus a couple separated by illness, etc., or is it one just basic daily fee for everyone?
It's one rate.
Pardon?
Principally it's one rate, yep.
Okay, all right.
And Senator, it doesn't include the supplements that a pensioner receives. It's the basic rate. So it
doesn't include the pension.
It's not 85% of the amount that someone would get in their bank account.
That's right.
Okay. So coming back to some of the residential contributions, in terms of the maximum accommodation supplement amount, do you have a forecast for what that will be on the 1st of July 2025?
Susan Trainer, Assistant Secretary, Home Residential Division. We don't have a forecast for what it will look like on the 1st of July 2025. Those rates are indexed on the 20th of September and the 20th of March each year. And so there will be an indexation point between here and the commencement of the bill. And so we don't have a forecast of what the actual dollar values will be at that time.
Okay. What about for the hotelling supplement?
The hotelling supplement likewise will have an indexation point of the 20th of March next year.
Is that the same too for the maximum non-clinical care contribution?
Yes, there will be an indexation point of that, but again, the fact sheet has provided what the current estimate is as well. So that's $101.16.
Okay, thank you. Just in terms of supported home, noting that there's going to be the 8 classifications and then there's the annual budgets that have been set out for those minus the 10% for care management. Have you modelled expected splits between the dollar amounts or the percentages that someone would require between clinical independence and everyday living services? So, for example, if I go to classification 8, if I'm reading it correctly, they get an annual budget of $78,000. In terms of that $78,000, have you modelled what you would expect someone at that level would require in terms of a percentage of that being clinical care, independence and everyday living?
We have, except that it will vary a little bit. So because each person in each classification will have their own requirements, there's a fair degree of variation. We've got, I believe, averages. What we saw, we did the trial of 22,000 people using the new assessment tool, and off the back of that, we can sort of determine some averages against which we can make some.
Can the results of that be provided to the committee so we can look at those 8 classifications and see what you're roughly expecting those percentages will be?
Oh, I think so, yeah.
All right, thank you. Yeah, if I can have that on notice, that would be super helpful. Chair, how much time do I have left in this round of questions?
Senator, you have another 5 or 6 minutes.
Okay, all right. I might go to RADs and DAPs. Can I confirm, in relation to the new maximum for a RAD, so that's going to 750,000 without having to seek an exemption, what percentage of that will the provider be retaining?
Senator, so the retention amount it would be 2% per annum, deducted monthly from that RAD, with a cap of 5 years on how long the provider is able to retain a component of the RAD.
And if I understand it correctly, DAPs are calculated off that room price. So how will the increasing of the maximum room price flow through to DAPs, and how much a DAP will be?
Sure. So there is a fixed equation that determines a DAP given a room price expressed as a RAD, which is based on an interest rate known as the maximum permissible interest rate. And then that formula effectively means as the room price expressed as a RAD goes up, so too does the DAP. So effectively, it is based entirely on the room price itself. So if the RAD increases, so too does the DAP.
Okay. Very interested in this interest rate. Who sets that?
That is based on the general interest charge interest rate, which is in turn based on a bank bill swap rate. But
Right.
it seems
it's a defined significantly
interest
higher
rate.
than actual cash rate.
It is, yes.
What's the reason behind that? What's the policy reasoning for that?
The interbank transfer rate reflects the real cost of money in financial institutions. That was the basis of it.
Okay, not quite sure how that relates to somebody having a room, but I'll worry about that later. So in relation to the retention part of the RAD, what conditions will be connected to that? So is there going to be conditions around what consumers get in return for them being able to retain more of that?
There will be no additional conditions associated with the retained amount. Once a provider has retained that, it effectively becomes consolidated revenue, although I believe the government set out in some of the announcement material that the expectation is that it will be going towards capital builds and upgrades.
Okay, so there's no requirement, for example, to improve services to retain that additional amount?
There's no requirement, no.
Okay. Just coming back to the RAD and the retention amounts, is that going to be in the rules or will that be in the legislation?
The 2% rate is in the rules. The 5-year cap is, I believe, in the bill.
Okay. Interested, given this framework then, what incentives exist to actually push down the market costs? Because it seems like this is the way this is set up, things can only go up. Is there anything built into this to actually try and push down the market cost of anything?
The cost of accommodation, Senator.
So I think it's important to note that one of the motivations for this reform exercise was that providers were not pricing their accommodation correctly and were not getting enough revenue from it. So
What do you mean by when you say not correctly?
well, they weren't covering their costs with their accommodation pricing. So part of the intent is that they will get more revenue for accommodation, not that they will get less.
Okay. Just in relation then to this increasing the maximum room price, so this is when providers need to seek approval to actually go beyond that maximum. Just interested to know, does the department actually track the number of applications made and how many are approved and rejected? Is that information kept anywhere?
It's kept, Senator. I think IHACPA keeps it.
Yes, IHACPA are responsible for assessing those applications, so they would have data about the number of applications and approvals.
And is that provided anywhere or publicly available or available to the Senate?
I think it would be, but we can get it for you.
All right, that'd be great.
We can talk to IHACPA.
All right, thank you. I might leave it there for this round. Thanks, Chair.
Thanks, Senator Allman-Payne. We're due to go to a break in a couple of minutes. So what I might suggest, if I have the agreement of senators, is that we just take 8 minutes now and return at, it's 10 to my time, so 20, I think that's 20 past 1 in the room. My maths is correct. So we'll just suspend briefly and then we'll be returning at that time. Thank you. The committee will now resume. I'm passing the call to Senator Pratt, then I'll return to the Deputy Chair and then, then I'll return to the opposition and then the Deputy Chair again. Senator Pratt, you have the call.
Thank you. Thank you to the department and the other entities here today. My first question for the department is about the enforceability of rights within the bill. The framework for the bill shows that rights are not individually enforceable in a court or tribunal. So my question is, how will rights be upheld?
Thank you for the question, Senator. I'll start my response by noting that the bill represents a really significant shift from the current legislative framework. So the 1997 Act doesn't mention individuals at all. So this is a completely person-centred piece of legislation, and the Statement of Rights is really central to that. The Royal Commission didn't envisage a direct path to litigation from the rights, and so that is reflected in the bill, and nor do we think that that's appropriate because there is a spectrum of breaches of rights, and different breaches necessarily would lead to different responses. So the first level within which we expect the Statement of Rights to be upheld is through the complaints resolution processes at a provider level. There's a new Complaints Commissioner, as you know. People can go directly to the Complaints Commissioner, or if they don't get a satisfactory resolution at the provider level, they can also escalate to the Complaints Commissioner. And we did make some changes following the exposure draft to make that role of the Complaints Commissioner more independent. It's now a statutory ministerially appointed position that has standalone functions in the legislation and she has her own enforcement powers. Where a complaint is made and that indicates that there may also be a breach of a registration condition or an obligation, the Commissioner can then take regulatory action. So some rights may be of such significance that they also, for example, breach the Code of Conduct or they breach the quality standards, and there are registration conditions that relate to those things. They have civil penalties attached to them under Section 144 of the bill. And it's also a requirement that providers demonstrate an understanding of the Statement of Rights and have practices in place to ensure that services are provided in accordance with those rights. So there are two levels of civil penalties that can attach when providers don't meet those requirements. Where something very serious has occurred and somebody is put at risk, or there's actual harm, or there's a death that occurs as a result of a provider's breach of rights, there are new statutory duties included in the legislation, which was also a Royal Commission recommendation. They carry very significant civil penalties, and where a provider has breached one of those provisions, there is a statutory compensation pathway as well. I think it's really important to note that the complaints framework has some new elements to it that will enable conciliation, as the Complaints Commissioner outlined earlier today. So a different approach to complaints resolution, but there's an escalating number of responses that can occur where there is a breach of rights. It's also important to note that rights need to be balanced, and none of those rights are absolute except for in relation to restrictive practices. So we've included some provisions in the bill to make that clearer, that rights need to be balanced. I think broadly, though, inclusion of the Statement of Rights very much represents a cultural shift to focus services on the needs of older people, and it will give people the language to talk about their rights and what they expect of the aged care services that they're receiving.
Okay, so the rights are enforceable through the Commissioner?
Through the regulatory framework, yeah.
Yeah.
And I don't think I mentioned that the bill doesn't exclude all of the common law protections or consumer rights that people already have. So what the bill outlines is in addition to that common law framework that already exists.
I'll turn now to the intergenerational report, and I know I want to put in context how this legislation responds to what it found in the context of the sustainability of aged care and of aged care spending.
Certainly, Senator. So the intergenerational report projected that between now and 2062-63, we'll see a tripling of the population aged over 80 to over 3.5 million people by 2062-63. The Aged Care Task Force included some stats on this and reported that the aged care funding in particular, as a government share of GDP, was projected to increase to 2.5% of GDP. That's the government spend on aged care would be 2.5% of GDP by 2062-63, which would be a more than doubling of that proportion over 40 years. The reforms, we don't have the figure all the way out to 2062-63 for you, Senator, but it is expected that the reform package will moderate that growth as a proportion of GDP. So the projections we have from our colleagues at Treasury is that by 2034-35, instead of having aged care government costs being 1.5% of GDP, they will be 1.4% of GDP. But in dollar terms, that will still be a year-on-year increase.
And how, in the context of this legislation, will it be used to know where those dollars are being spent?
Sorry, could you try that again, Senator? You dropped out for just half a second.
No worries. So how will we know, under this legislation, where that spending is occurring within aged care?
How will we know where?
So
what is it being spent on, and where is it being spent?
Senator, I might start. We are, through quarterly and annual financial reports, collecting information from our providers on how they're allocating the dollars that we're providing to the various parts of the service that they deliver. And the kind of one of the most important elements is around the dollars that they provide to care, because we're obviously trying to lift the number of care minutes that providers provide to residents in residential aged care. So Ms Connolly might be able to add the processes that we're engaged in there.
So in addition to residential aged care granularity around where the money is going, the new Support at Home program will have additional granularity around the services that are actually being accessed by participants in home care. So we will have itemised invoicing and data that tells us where the need for older people in Australia is in terms of their aged care needs. That will help us to better target our aged care programs. So that will extend both across the full spectrum of aged care, from in-home to residential aged care, at a time where we are looking to be much more targeted and much more efficient with the public money that we are spending.
And Senator, I just would add that obviously the government, in looking at changes to co-payments across residential aged care and support at home, has that important principle of that clinical care is free and not subject to any co-payment, which was something that was kind of, you could see in the recommendations and the commentary in the Royal Commission report. And then obviously in residential care, we are asking providers to meet new benchmarks. So they have been at an average of 200 care minutes for a person per day, and that benchmark's moving to 215 care minutes in October.
It shifted from the 1st of October.
It's already shifted. I'm into October. And also we've obviously got the requirements around 24/7 nursing. And so they're kind of some of the signature ways in which we're really focusing providers in on that higher level of care for individuals in the system.
Thank you. I'll turn now to the Aged Care Task Force. Who was represented on it? And in terms of its findings, how does this bill respond to that report in its priority areas?
So I'll just, while Ms Traynor is finding the membership so that we can provide it to you, the bill responds to the task force with the reforms to means testing in both supported home and in residential aged care, and the reforms to accommodation payments in residential care. So they're the three major tranches of amendments to the bill, and that the bill delivers. And as Mr Lyon said, one of the important considerations across all of those was the desire that clinical care should not have a contribution attached to it, but there should be contributions to independence and everyday living. So the means testing framework of the bill is a response to the task force, as is the accommodation payments. And Ms Traynor, do you want...
Certainly. In terms of the membership of the task force, it was chaired by the Minister for Aged Care, and then the Deputy Chair was Nigel Ray, PSM. There were 16 members of the task force, each of whom was appointed as an expert or policy leader with the ability to provide representative advice for their respective sector. That included representatives of providers, older Australians, First Nations persons, unions and workforce representatives, as well as other subject matter experts who could speak to the financing of the aged care sector and its relationship with the broader healthcare sector.
Thank you. You've touched on already in evidence today about the rules and Chapter 4 of those, and I guess the development of those during the course of that's happening now. I'm interested to hear about that consultation process, how it's going to be conducted, and I guess in that context to also reflect on how we manage our work as a committee in hearing about those issues. I'm imagining that you will be responding to feedback in the development of those rules, and then some of them will become available in the course of the inquiry.
So I'll start by just noting that a number of the matters that will be covered in the rules have already been consulted on. So the task force matters and most of the matters in relation to the regulatory framework and the new Support at Home program. So what we'll be doing is consulting on the detail that's contained in the rules, and the consultation process will depend on the rules themselves. So, for example, the service list, which has been published at the moment, we've got that on the department's website, and we've opened that for written submissions because they're quite detailed. For other aspects of the rules, we may publish them alongside a survey that asks specific questions about things that we're looking for stakeholder feedback on. And we may also have roundtables or webinars on matters that are of particular interest to, say, providers or individuals who are receiving aged care. So the consultation approach will depend on which rules and which topics it is that we've released. It is worthwhile noting that whatever we are putting out or whatever we're talking to the committee about represents draft rules for consultation, so the rules won't be finalised until much closer to commencement when they're made by the Minister and tabled. So really we have from now until, if the bill passes, commencement to consult on the rules, and the Minister has made a commitment to do that.
Okay, so we can, as a committee, separate those out somewhat in terms of us looking at the legislation framework and the context of the rules, if and when it comes up. We can respond to that, but it's not finalised until that commencement and the new rules are tabled by the Minister.
That's right, okay. Senator, and they are also subject to disallowance.
No, I do sit on the Delegated Legislation Committee, so I'm sure they'll come up there as well. In terms of individual contributions,
Senator,
last question.
I just need, if this could be the last question, then we need to rotate. Thank you.
Okay. Individual contributions for support at home, how will those work? I know that's an issue of significant interest.
So, clinical care will not attach an individual contributions, but for independence and everyday living, and the services included in those two categories are in the services, the service list for support at home. People, depending on their means, will pay a percentage of the services that they receive, and when we ask older people about their preferences for payment arrangements, that's something that they consistently say that they prefer. And so there's a kind of three.
I meant in the context of that question to ask about old existing and new recipients as well, and how that will vary according to their means and circumstances.
For new recipients, a full pensioner will pay 5% of the cost of independence and 17.5% of the cost of everyday living. And for new people to support at home, a self-funded retiree will pay 50% and 80%. And between those two, for part pensioners and people who hold a Commonwealth Seniors Health Card holder, their contribution will increase from 5 to 50 or 17.5 to 80, depending on their income and assets. So,
but Senator, importantly, and the task force said we had to kind of think this through about existing versus new. Everybody who is currently in the system in the Home Care Packages program or Commonwealth Home Support program will pay the same or lower fees than they currently do for and through their whole aged care journey, including into residential care. So that includes people who've been assessed and are on the waiting list for services. So the principle here is trying to make it very clear for the existing population that they won't be captured by that new fee structure that Dr. Hartland just talked about.
Thank you, Chair.
Thanks, Senator Pratt. I'm returning the call to Senator Ruston. Your position.
Thank you very much, Chair. Just quickly before I move on to another line of questioning, in response to some questions from Senator Ullman-Payne around the MPIR, just wondered if there'd been any consideration given to putting a floor or a cap on the MPIR?
Not in the current bill. The government has announced an accommodation pricing review, which will give further consideration to some of the recommendations of the task force that have not been enacted in the immediate response, and that did include consideration of the appropriateness of the MPIR and the current relationship between RADs and DABs.
When's that review likely to, the terms of reference, to be developed?
I think that the government indicated that review would occur over the next 2 years.
Okay, thanks. Can I just move on to the provisions in the bill that relate to supporters and representatives? So I'm keen to understand when and how it was decided to introduce supporters and representatives into this bill, because from the best of my investigation, there was nothing that referred to it in the Royal Commission. So I'm just interested to understand where this came from.
So there's only currently in the bill a reference to supporters, not representatives. So that was a change made following the exposure draft. They were introduced, so the Royal Commission did broadly make reference to the need for autonomy and the presumption of legal capacity and the right for people to make decisions about their care and quality of life and right to social participation. Not unlike a number of other Commonwealth statutory schemes, it is necessary for the Commonwealth to know who is somebody's representative so that information can be shared with those people lawfully. And so similar schemes exist in the social security legislation, in the NDIS. The reason it needs to be included in the aged care bill and why it's not in the current framework is because the current framework doesn't mention individuals at all. And now with a framework where individuals are going through an assessment process that's legislated and they have review rights, it's very important for the Commonwealth to know who is supporting that person, or in circumstances where that person can't make a decision for themselves, who their representative is who can lawfully do that.
And sorry, just to the reason the supporters and representatives was placed in the exposure draft of the bill is because of work that the Australian Law Reform Commission did on supported decision making. So that's the authority we used for that.
So in terms of your investigations after that particular issue was raised through the law reform process, what were your concerns around the existing provisions that occur within states and territories around power of attorney? And, you know, what was the logic process that said instead of trying to work with that existing mechanism, which many older Australians already have in place, to actually seek to duplicate this and the impact of the confusion of the duplication of what you're talking about here as opposed to the power of attorney as it currently exists?
So just to clarify, it isn't a duplication of the state and territory arrangements. It's effectively the Commonwealth recognising and picking up those state and territory arrangements. It doesn't create a new separate framework. They're carefully constructed to operate together. It's really about the Commonwealth knowing who those representatives are at the state and territory level. And the reason that the Commonwealth needs to do that is because the arrangements in each state and territory are different. And aged care is a national scheme, so we need some national consistency around how we recognise those different arrangements in each state and territory.
So am I reading into what you've just said that there actually will be no impact or requirement in relation to the individual to do anything additional in relation to this? It's just something that you're seeking to legislate to enable you to get access to existing state and territory provisions that exist within those states and territories in a way that allows you to be able to fulfil your obligations of the bill. So there's no additional burden will be placed on anybody.
It will be necessary for people to notify, and those arrangements exist with My Aged Care currently, but they're administrative arrangements. But those state and territory arrangements operate on their own terms and can operate despite the aged care bill, and will operate in other sectors outside of aged care. So there is a requirement for people to notify the department about those arrangements, but they don't need to necessarily put in place new arrangements. And I think it's important too that there may be people who don't have state and territory arrangements in place, and so those people can nominate someone as their supporter in the context of aged care, and that person can then lawfully receive information relating to that person's aged care, can assist that person to make decisions in respect of their aged care, and can interact with the government effectively on behalf of that person.
So what you're effectively saying to me is if somebody's already got a power of attorney in place under a state or territory law, there's an automatic process where that person becomes their supporter as such without anything further needing to be done?
Not automatic. It needs to be notified. So, and the reason that it needs to be notified is that there's no national register of powers of attorney or guardianship arrangements. So the Commonwealth needs a mechanism to be able to obtain that information about who someone's representative is, which is why we've got the arrangements in the bill for supporters to be notified to the Commonwealth.
Okay, so whose responsibility is to identify the supporter?
Well, it'll either be the older person themselves, or if a person is acting as a guardian or is a power of attorney, that person will need to notify.
Okay, well, we might unpack that a little bit further at a later date because it seems to me like it's a little bit confusing. So can I just, in terms of entry into the Commonwealth aged care system, in relation to access for individuals aged between 50 and 64, and in the section that relates to it, in terms of the eligibility determination, it refers to exceptions being risk of homelessness and Aboriginal Torres Strait Islander peoples. So I'm just keen to understand what it is. Are they absolutely the only exclusions for access, or is there other? Also, what are the exceptions? Because my understanding is it was homelessness and Aboriginal Torres Strait Islander people. Are there any other exceptions, or are they the only two?
There's no other exceptions.
Okay, so for instance, if somebody, for instance, had early onset dementia, where obviously the majority of our care expertise in relation to dementia resides in our aged care homes, is there a mechanism or process through which somebody who's got, say, early onset dementia would be able to access aged care?
Senator, we've been in discussion with state and territory governments around the provision of more appropriate accommodation and support for people. There's a number of different examples, including the one you mentioned, for people who are under 65 to access other than aged care.
Sorry, I suppose I was just trying to, Mr. Lai, to understand, particularly as it relates to early onset dementia, which unfortunately we're seeing more commonly occur, that all of our resources, well, not all of them, but a large amount of our resources in relation to dementia care reside within aged care facilities. And I just wondered what the process was of why homelessness and ATSI were considered as exceptions, but there hadn't been any exception put in for early onset dementia, or I suppose conditions that would render somebody as probably needing the kind of skills that exist within aged care. Why that was excluded?
Yeah, I mean, I think that the practical impact of early onset dementia is not dissimilar to somebody who has mental health issues or a range of other different medical issues in that younger population, and those people have been put into aged care traditionally because there is no alternative at the state and territory level, no appropriate accommodation. And obviously the Royal Commission had very big concerns about that population being in aged care inappropriately with an older group of people in a setting that they said wasn't appropriate for them. And so the bill does tighten access for that, and we are in conversation with the states around how do we provide appropriate housing and support for people under that age group, except for people who are long-term homeless and Aboriginal and Torres Strait Islander people who may have shorter life expectancy from premature ageing. Yeah,
I don't think I'm referring to more generally your I think we all will accept that that was a very strong recommendation of the Disability Royal Commission. I'm talking about people specifically with dementia. And I'm just interested in why that was specifically excluded.
And Senator, my understanding is that that younger onset dementia is largely covered by the NDIS.
Yeah, and that's fine in that sense, but what if the care is best provided in an environment where you've got the dementia experts?
Well, Senator, that is the same argument for why people argue that somebody who's got cancer and palliating, who's under 65, should come to residential aged care because there's a greater level of expertise there. And the Royal Commission had a strong view that aged care wasn't the destination of last resort for people who couldn't otherwise get appropriate support and housing for someone their age. And so it's difficult because it is small numbers of people, but there isn't a great supply of alternatives for that small group of people who are non-NDIS eligible. But nonetheless, that's the challenge, the WIPERAC challenge that we've been set, which is to make sure that aged care isn't the default destination for these people. And so, you know, to your point specifically, it is about how do we help states and territories develop that expertise around dementia to provide alternative places for people to be appropriately accommodated.
Okay, we'll leave that one there. In the bill, there seems to be a bit of a change around the requirements of providers to either conform or comply. I'm just keen to understand what the difference between conform and comply is in terms of how it relates to what is required of a provider. Because in the exposure draft, there seemed to be, it was largely comply, and now this word conform seems to have popped up. I just wondered what that meant.
Yeah, so we've deliberately used the word conformance because we wanted to link it to the registration audits. It is the one of those things that is judged by those performance, those registration audits, and to be clear that it's a forward-looking measure. So anything that relates to the standards there and relates to that audit process, we've used the word conformance rather than compliance to create that distinguishment.
Okay. So just as an example, how would the interaction of the conform versus comply play into, say, a provider's responsibilities in relation to the star rating system? They be conforming or complying?
So the impact of the new legislation on the star rating system is currently being looked at, also in conjunction with findings from the star ratings evaluation, which we'll soon receive.
Okay. Just interesting, sorry, I'm jumping around all over the place a bit here. In terms of the regulatory mechanisms that are contained in Chapter 6, just keen to understand, what are the explicit powers of the Commissioner?
Sorry, Senator, was the question, what are the explicit powers of the Commissioner?
Yeah.
Yeah, well, that chapter picks up the powers in the Regulatory Powers Standard Provisions Act. Just to give a general overview of the powers of the Commissioner, they relate to monitoring, investigation. There's a specific power relating to entry of premises without warrant or consent where someone's safety is at risk. That's a very limited power. Then there's the ability to enter into enforceable undertakings, issue infringement notices, and seek injunctions. And then there are the notice provisions that the Commissioner outlined earlier today.
Okay.
Senator, I just need to rotate.
Sorry?
After the question, I'll rotate.
Okay, yeah, I was just interested to understand the difference between the powers that as they apply to the new Act and what are existing powers. So if you could, yeah, I mean, it may be more than a quick answer to a question, but yeah, what powers are new and what powers are contained in existing legislation?
So that,
if any?
I think just to broadly answer that question, those are existing powers in the current framework. They apply differently to the registration conditions and obligations. So the structure means that each of those obligations now very clearly, because they have a civil penalty attached to them, are now subject to those Chapter 6 powers. So it's a clarification of the framework and a much clearer pathway from each of those conditions and obligations through to the regulatory powers than we currently have in the current Aged Care Act. Because largely those provisions in the Aged Care Act at the moment evolved over time in response to particular issues. They may have civil penalties attached or they may not, or operate in different ways. So it's just streamlining the process and making it very clear where the Commission has powers to act.
So just finally, you don't have to answer this now, I'm happy if you take it on notice. I'd just be really keen to understand in terms of those powers, where powers have been changed, increased, removed, just to get some clarity. I understand entirely what you're saying over time, but I'd just be really interested to understand where those powers have changed from now to what will occur under the new Act. Thanks, Chair.
Thank you very much, Senator Ruston. I'm passing the call to Senator Allman-Payne for a 10-minute block, then I'll do the same for Senator Pocock and we'll return to the opposition with any remaining time. So Senator Allman-Payne, you have the call.
Thanks very much, Chair. I'm actually going to circle back to the issue that Senator Ruston was asking questions about in relation to eligibility. Specifically interested in the clause relating to risk of homelessness. Will there be a definition of that's provided?
Not a legislative definition. We plan to manage that through policy guidance.
Okay, so who will be making that judgment?
It will be the people who are delegated to make decisions around eligibility.
So they make overall decisions, so that's when someone puts an application in, we're talking about those staff?
Yep.
Okay. What does informed prior to making the election mean? Because it talks about the fact that the person has to be informed prior to making the election of any other services that may be available. Interested in what that means and what sort of deliberative process is going to take place. Is it expected that it would just be a phone call? Is it an actual interview with people? Like, how will that be determined?
So during the process of determining eligibility and assessment, the expectation is that there will be a conversation with the individual about the alternative services that are available to them outside of the aged care system.
Okay, and if that person just says, I don't want to use them, then it's...
The other services, Senator.
Yeah, like, or will they be supported to access those services, like, or is it just literally a conversation and they go yes, no, and then the decision's made?
I mean, there's currently quite a involved process that's happening, which we are engaged in to make sure that we don't have people coming into the system who, so for example, somebody who has complex needs and a state government says, for example, who's in hospital and the state government says this person's at risk of homelessness if they don't come into aged care, that would not meet the criteria. We are stringently working procedurally to make sure those people test other services to try and make sure that they don't come in, and we have dramatically reduced the number of people coming into the system who are under 65 for that kind of reason.
So are you expecting that the process for determining whether someone can enter aged care due to risk of homelessness will be the same one that's being applied now?
It needs to be at least as strict as it currently is, because otherwise we will see people use that as a means to get people in who the Royal Commission said it was not an appropriate place for, yes.
Is it possible for us the committee to be provided with the guidance that's currently used to help inform those decisions? Great, that would be good. Just in relation then what modelling has been done to estimate how many people under 65 would enter residential aged care under the eligibility provisions as set out in the new Act?
I don't believe we've got any modelling, but we do have current data under the current rules of the Act. About how many younger people we have in aged care. Sorry, I'm just trying to find the latest data.
I guess what I'm keen to understand is, so is the assumption just that with the new rules you'll take whatever you've currently got as the numbers, weed out the people who would no longer be eligible, and that's the assumption?
Sorry, if you're already in aged care, we're not going to remove people from...
No.
Yeah.
I guess I'm trying to understand though, obviously then my question is, have you estimated how many people under the new guidelines or the new legislation would be eligible to come into the system who would be under 65? And you said you haven't modelled that. So my question then is, are you just assuming then that if you look at who's in there now, what proportion, percentage, the numbers, and then if you overlay it with what the new requirements are, that's roughly how many people you'd have?
That would be the maximum. I think, Senator, if we gave you the stats that we have over the last, say, 3 years as we've tightened eligibility, so the Aboriginal and Torres Strait Islander cohort and homeless cohort would be relatively constant, and it's not large numbers, but that we remove that from the stats now because they're appropriately housed according to our policy. But what would be important to show you is the gradual tightening of the flow of others who are not NDIS eligible.
It's not so much that I want to understand that number, it's that I want to know whether you've modelled so that in your numbers of people who are going to require care going forward.
Our target is zero, Senator, zero entrants for that group, but it currently isn't at zero, but that's our trajectory.
Yeah, all right. Well, if you can provide those stats, if you've got them, that would be useful. Obviously excluding people who are Australian non-residents, but apart from them, in what circumstances would a person under 65 with a disability or impairment be eligible for residential aged care but ineligible for the NDIS?
They wouldn't be.
Okay, so not eligible at all?
If they were long-term homeless.
Okay.
Or Indigenous, yeah.
Okay.
Yeah.
Has the funding of non-NDIS participants in aged care been included in the Foundation Disability Supports negotiations with the state and territory governments?
I'm not sure. Well, we can have a look at the question to that, Senator, the answer to that. Small numbers, but I'm not sure whether we have.
If you could get us an answer on that, that would be good. Just in relation to people currently in residential aged care, what proportion of those people are paying a full RAD?
Not sure whether we know that.
It is reported in our financial report into Australia's aged care sector. I can look it up in a moment.
Okay. Well, if you're looking it up, I'm just keen to know what proportion are paying a full RAD, what proportion are paying a full DAP, and who are paying partial RAD, partial DAP. That's my last question, other than to ask, just in relation to the information that I asked for earlier in the first round of questions, and you'd indicated that you could provide that on notice. Just interested to know how soon we can get that. Is it possible to get that next week so we've got it before our next round of hearings? All right.
So, Senator, while Ms Trainor's looking for the stats, 55.6% of residents are what we call non-supported residents. So those are residents for which the Commonwealth does not pay any accommodation supplement, either full or part, and so they negotiate a price with the provider, and so that's the proportion who may choose to pay a RAD or a DAP, and of course many of them pay a RAD DAP or a RAD DAP combination.
Yeah.
And we're just looking for the stats on the percent who pay RADs. But
yeah, if you can provide that on notice early next week, that would be great. All right, I'm done then. Thank you very much. Thanks, Chair.
Thank you very much, Senator. I believe we have Senator Pocock in the room. Senator Pocock.
In relation to ACAT assessments, and just on the question about questions on notice, I was wondering if the department intends to respond to my question on notice SQ 24003040 from estimates.
We would intend to, Senator. Absolutely.
Why is it so?
Why is it so
taking
late?
so long?
It'll be going through the process, Senator. So there's no reason for the delay. Just we take a lot of questions on notice, and it does take a little while to finalise and provide those responses.
Thank you. It's good to know that it's working through the system. Last time we spoke about ACAT assessments, the average wait time for the ACT was 75 days, which is the longest in the country. And 33% of ACATs are being conducted in hospital, which is the highest proportion in the country, and we sort of discussed that. I wrote on the back of that, I wrote to the ACT Health Minister to sort of try and get an update and push the ACT government on this. And she said, and I'll quote, "Despite several requests to the Australian government over recent years for additional funding to increase the number of assessors, no additional resources have been provided." She also said that in addition to increased demand for ACT residents, ACT also conducts assessments for interstate residents receiving care in ACT hospitals who require an assessment as part of their discharge planning. So I was just interested to just get the Commonwealth's side of the story around lack of resources for the ACT to do this.
Senator, I think when we previously talked to you about this, that we'd had conversations with the ACT government off the back of your questioning in estimates, and that there was a remediation plan with the ACT government to bring them back to acceptable timeframes. They had fewer than, I think, fewer people allocated to do assessments than they were funded for, and they acknowledged that, and that we were working with them to improve that. So that's not quite consistent with the answer you've been given from the ACT government.
I guess that was my concern, is that I heard that from you, that they actually couldn't fill the positions that you'd funded for them, but I'm hearing from them that actually they're asking for more resources and you aren't giving it to them. So I'm just trying to actually get to the bottom of this.
A couple of comments on that, Senator. So in relation to the remediation plan, our understanding is that there has been progress made. So the aged wait list, so people who have been waiting longer than 75 days in the ACT for an assessment, has halved over the past few months. So previously it was over 750 and now it's sitting at around 380. We did talk with you last estimates about the fact that the wait times, because the ACT was working on that aged profile, the wait times would kind of look worse before they got better. And so we're not seeing the wait time that you quoted necessarily coming down a lot, but we are seeing the wait list, so the number of people who have been waiting for a long time, materially reduced. So that is good progress. Certainly we have still a way to go with the ACT in a number of other jurisdictions, and we're continuing to work with them closely on that. A big part of the puzzle is the move to the single assessment system. And we've made some good progress. From the 1st of July, our integrated assessment tool went live. That is the tool that will support not only current assessments but also assessments under the new Aged Care Act. It's a tool that's designed to be used regardless of which program people are going into, so we're seeing some harmonisation. It is a stronger tool in terms of the inputs that are taken and the algorithms that are utilised. What we're also doing, as well as the tool, is shifting our workforce arrangements so that we will be introducing, as well as state and territory providers of ACATs, essentially introducing additional providers, so that where we are seeing particular jurisdictions might be struggling to meet the demand, there will be alternative providers that can provide that assessment support.
Well, they'll be private providers?
Not necessarily. So we're going through an open tender process at the moment.
Okay.
That's on track to be finalised in December, and the results of that tender will be made public. We'll go through a proper transition and communication program to make sure everybody's trained, the workforce is ready, and they will be rolling out to the new providers over the balance of the 24-25 financial
That's
year.
good to hear. Thank you.
Senator Pocock, just a reminder, we are looking at this specific bill and we've got a number of questions on it still from senators, so I would just encourage your questions to relate to the bill that we're looking at right now.
Sure. The Minister said that it'll take 3 months to get home packages if the bill passed. I was keen to sort of understand how that's actually going to work with the current ACAT system, which is nowhere near 3 months. But I'll try and do that. Do you have the average wait time for the ACT and nationally handy?
Wait time for an assessment?
Yeah, for now.
So I do. So the ACT wait times for ACAT, so for complex assessments, the median wait time is 46 days.
Mm-hmm.
And the average wait time is 42 days, and I should clarify that's for low priority candidates, of which the bulk of assessments are classed.
Mm-hmm.
So the ACT is sitting above that average, just a little. In terms of the Minister's statement about the 3-month target wait time under support at home, that's a post-assessment wait time. Obviously, all of the things I mentioned around the single assessment system are designed to bring that average 42-day median wait time for assessments down, so introducing a broader suite of providers in the market, as well as providing a payment per assessment will incentivise faster access to our support at home program. In relation to wait times for home care packages, at the moment there remains pressure on home care packages, and we are seeing that continue. Additional packages were funded through the budget. They are starting to roll into the system and making an impact, but there does still remain a fairly material wait time for home care packages. As the Minister said, in relation to the support at home program, we do anticipate those wait times will reduce. It will take some time as we work through grandparenting arrangements for people who are on the existing program. But we are working very hard to make sure that those wait times, which are expected to be at or above 6 months from 1 July 25, will come down to that 3-month wait time target from 1 July 27.
Okay, thank you. Yeah, one of my concerns has been I was at the CODA Seniors Expo and had a number of people come to me saying what great news it was about the 3 months, and I'd say, well, actually, that's only once you've got your assessment. I guess there's a huge issue here in the ACT, so it's great to hear that you're working on that. Just finally on ACATs, and then I've got some other questions. The statement that there's a whole bunch of people from outside the ACT getting ACATs. Do you have the numbers of what proportion of ACATs in the ACT hospitals are for non-ACT residents?
I don't have that data.
I assume it's a small number.
I'm not sure. I don't know that we would be able to get it, but we'll see if we can.
Okay, maybe just on notice then.
Yeah.
Okay. The 3-month wait to get a home care package, is there any sort of legislative or regulatory basis, or is it just a sort of aspirational commitment?
There'll be a prioritisation mechanism that will be made through a ministerial determination. It's not on the primary face of the legislation. I'm just looking to my colleagues to confirm that.
So what does that actually mean? Like, is 3 months what the minister hopes that we'll get to, or is there something in the regs that's going to say, you know, you got to get it done in 3 months?
No, there won't be anything in the legislation or the rules that will require that. It's a target that we will work towards.
Mm-hmm.
But Senator Nick Morgan from the Support at Home Reform Branch, the Support at Home program, when it commences, will commence with funding that grows in line with the projected demand of older people in the community looking for support at home.
Okay, thank you. And so another question on, from seeing the Minister's statement, it was from July 1 next year, I think, when the 3-month thing comes into effect. But I'm interested because, you know, the current wait time for a Liverpool package for someone who is medium priority is 12 to 15 months. So I'm wondering, like, over what time frame are we getting to 3 months? Is it within on 1 July in 2026, in 2030? Like, what's
so it will take some time. So
the Minister's, it's good marketing, but like, I'm just trying to manage expectations with people who come to me and are excited about the fact that from July 1 next year they'll have less wait.
So the Minister was clear that it was from 1 July 2027 that the 3 months would apply.
And do you think it'll happen by then?
That's what we're working towards, Senator.
Okay. Earlier this morning we heard from the Inspector General that the bill in front of us doesn't guarantee people access to aged care if and when they need it. He said that it continues a system of rationed care. Obviously, recommendation number 41 from the Royal Commission that the ration system be replaced with a demand-driven system. And looking at the statement of rights, we can say that, there's no actual right to aged care. Rather, people have a right to have their needs assessed for aged care. I'm interested, sort of, under these changes, people will be contributing far more in their aged care going forward, particularly for self-funded retirees. If that's the case, why should people have a right to home care, not have a right to home care or residential care if they're paying for it?
So, Senator, the Inspector General is referring to the kind of funding mechanism, which is a demand-driven appropriation versus a capped appropriation, and he made a reference to pensions being a demand-driven appropriation. Our modelling behind the development of the Support at Home program factors in the growth in the ageing population and demand for services. And so Mr Morgan talked about the growth. It's 300,000 additional places over the next decade. And if you think about the current program, it's about 300,000, just shy of 300,000 places today. So it's a doubling of that program over time. And that's designed to match that 3-month wait list that the government's committed to. Mm-hmm. So effectively what we're trying to do is make it meet demand, which is, and so the mechanism by which you do that, the Inspector General was right, it is a capped appropriation. So if the population seeking services exceeded our modelling, we would go back to government and get additional packages, get the government to agree to additional packages to meet that demand. The intention is that no one waits longer than 3 months. So we think we're meeting the spirit of what the Royal Commission talked about, but I think the concern is just that when you don't have a mature program, that these costs can bounce around, and you want to be confident that you have a handle on the total fiscal cost of what is a very, very big social program. And a capped appropriation is a better way of managing that. You don't want to get a program that runs out of control and then the community lose faith in that, or say that the government's not running that program properly, and then we end up losing that social program. And obviously there's been a lot of discussion about the NDIS and that costs have been higher than what people estimated. and we don't want community to lose support in aged care services. So,
but everyone's getting old. Like this is.
Well, that's
fundamentally it's fundamentally different in my view, because we're saying to older Australians that just to clarify, like, is everyone who needs a home care package guaranteed one, or are they just guaranteed an assessment?
They're guaranteed an assessment, but obviously the funding that government has committed to is aimed at matching the population who are demanding a service, who are seeking a service. So the intention is to make sure that there's no wait list beyond the agreed.
And that's 300,000?
It's 300,000 over the next 10 years.
So it's over 10 years. So if there's more, if you're beyond that, then...
If we found demand exceeded that, then we, as we've been doing and government has been supplying, we've been going back to government saying hey, demand is higher than what we estimated, and they have released more packages, have made a decision to release more packages. And so, but we think with the design and the program we've got and the commitment the government's made, that we will get to the 3-month target by 1 July 2027, and then we want to hold it there.
Okay.
At this point, I'm going to rotate back to the opposition. So,
could I have one final question, Chair, and then I'll...
Well, if it's brief, because Senator Kovacic is due for the call,
sure.
finishing 10.
Just a question on RADs. I heard earlier Senator Payne was asking questions, and I was interested why the 5-year cap is in the bill, but the 2% amount is in the rules, and whether you're planning on changing the 2% in the rules and why it's not on the primary ledge.
I think that's simply a matter of when certain elements were finalised compared to drafting of the bill. There's no immediate intention to change from the 2% retention rate.
So you'd be happy for them to put in the primary?
If that's a matter for government, yeah.
Okay.
Thank you, Senator Pocock. I'm returning the floor to Senator Kovacic, who's joining us by teleconference. Senator Kovacic.
By Senator Pocock. Can you give us an indication of how many people are actually currently in hospital waiting beds, waiting for allocation to residential aged care?
Nationally, Senator?
Yeah, whatever data you've got nationally or state by state, whatever you have there.
I'm not sure, Senator, we've got a... we can certainly come back on notice and give you give a figure. We have I do have a figure for... because the Commonwealth doesn't... The Commonwealth's collection of it is 2022-23. So states collect their own figures and the Commonwealth ends up with those figures. So 1.3% of all public hospital separations of older people occurred where the older person was coded as waiting for aged care services, which may indicate they're part of that group that's commonly called longer stay older patient cohort.
Do you have the actual numbers as opposed to, percentage of patients in public hospitals? Like, do you actually have the numbers of how many older Australians are in hospital beds waiting to enter residential aged care at the moment?
No, we don't have that data. The states, we have asked for that data from the states, but we don't have that data. So the states from time to time put figures out. But we have asked for that because we're in the middle of a process of working with them to try and see if we can improve the transfer of people from out of hospital when they don't have a medical reason to be there.
Because that kind of data would be very valuable to you, particularly as you talk about being, a rationed system. You need to understand what the demand is for a system that's rationed, and at the moment we don't actually seem to know exactly what that is.
Well, that's not quite right, Senator. We do have a sense about demand for support at home and residential aged care, and that's, we were saying before, that's what we've modelled into the future and why the government is committed to a very dramatic increase in places for people to be cared for in the home. Obviously, that group of longer stay older patients is captured in that modelling, but the proportion, who are coming from that from that location, as opposed to applying from their home or applying from another place, that we don't have those exact figures in a contemporary sense. We've got them for 22, 23, but not today.
Okay, all right. In relation to the ACAT assessment question that were asked a little while ago, could you sort of give me sort of a sense of, is there any particular reason why clinicians within the hospitals aren't able to conduct those assessments? Why are we waiting for specific ACAT assessors to do that?
Senator, we actually find that in-hospital complex assessments are conducted in a very prompt time period. I'm just looking up the data.
And our ACAT assessors are in the hospitals?
So the average time nationally to complete in-hospital ACAT assessment is a median of 1 day, an average of 3 days.
Okay, so very quick, so you don't see a need for it to be conducted by clinicians. And is that across the board? Is there a significant disparity across any of the states or territories in relation to that?
I'll just clarify, I didn't make any comment around the need or otherwise to conduct by clinicians, and I should confirm that under the new single assessment arrangements, those in-hospital assessments will continue to be conducted by states and territories who run those hospitals. We think that's a sensible measure, and especially noting that they are doing it very, very efficiently at the moment. And sorry, I've forgotten your question.
I think, Senator, if where you're going is that you're concerned that there's not timely ACAT assessments, which is causing the long stay issue, I'm not sure that we think that is the issue. I'm obviously talking in great detail with each jurisdiction.
What I'm concerned about is, someone's become ill, they've been in hospital, then they're waiting for an assessment, and then they're now waiting in hospital because it's not safe for them to go home based on that assessment. But we actually don't know how many people are there waiting for how long to get into an residential aged care. So my concern is, at this vulnerable point, there is, this, ongoing waiting and assessment sort of going round and round. So whether we're managing for that effectively. What we're doing here.
Yeah, to give you a sense, we're working very, very closely with each jurisdiction, and so there's a range of things happening in hospital. And so, yes, one of the things is cultural. Geriatricians and clinicians reaching a different judgment to an ACAT assessor or we would around a person's ability to go home with support, and sometimes that is because they don't have line of sight that a person has a pre-existing home care package at home, and so people coming in to look after them. Now that's more of a cultural issue or a need, us needing to make sure we get better concordance with those clinicians about safety of discharge. So there's quite a few issues and there's a preference in hospital to discharge to residential aged care when we think people's preference clearly is to go home. And so we're working with the jurisdictions around that. How do we kind of make sure that more people can return home than to residential aged care by default? And then to be fair to the states, there are structural issues as well. In some cases we might not have a residential aged care bed in a facility where people have a capacity to take somebody with the behaviours associated with dementia. And so in that case, we are working with the states around how do we kind of bring more beds back online or think about new facilities, or how do we use our dementia-related support services to help residential aged care to be confident to take somebody out of hospital. So there's not one reason for the long stay issue, but we are working very, very closely with the states around this. We're very committed to, and we think we can make a big difference to helping people to get out of hospital more quickly, safely.
Sure. And sort of two very quick questions to finish up on.
We're about to finish, so this will be the last question, please.
Thank you. The first one, happily to go on notice, the current wait list for ACAT assessment broken down by state, if we could please have that. And then my final one just relates onto the back end of that in terms of, waiting in hospital beds for aged care assistants. I note that you've said you've asked for the states for the information and you're waiting. Like, how long do you have to wait for that? Is this an ongoing issue, or is this sort of data that you're seeking, quarterly, biannually, or whatever it is, and there are just delays in receiving that data?
Oh, it varies. It varies by state, Senator, and sometimes it's because it's not easily centrally captured at the state level because hospital-based data. In some cases we get it, but it lags in a time sense, and so we've kind of we've moved beyond asking for data and trying to work at a regional level with states around individual hospital or regional populations and saying, how do we make a difference in those locations?
Okay, so to be clear, you're actually no longer asking for that information.
Oh no, there's still a process by which we want to reach agreement with the states to have an ongoing capacity to collect timely data to monitor the policy, but it's not going to land quickly.
Okay.
Thank you, Mr. Lai.
And just confirming that I can have that ACAT data on notice.
Yes.
Yes, he nodded, Senator Kovacic, which he wouldn't have been able to say. But thank you very much, Mr. Lai, and to the department for your evidence today. That does conclude today's hearings, and I would like to thank all witnesses who appeared, to Hansard Broadcasting and our Secretariat for their assistance. The committee has agreed that responses to questions on notice should be provided by Thursday, the 10th of October. The committee stands adjourned. Thank you very much.